Ma'am, please start in 3, 2, 1. Please start. Yeah, ma'am.
Namaskar and good evening, everyone. I welcome you all for the second day of today's webinar on updates in medical oncology 2023. And with immense pleasure, I would like to invite Dr. Sampath Kumar, who is Senior Consultant Medical Oncologist, Magnum Oncocare, Bangalore, for the welcome and introductory note and to take the proceeding forward. Over to you, sir.
Thank you, Likita. Good evening, all. Today, I welcome Dr. Lokesh KN, who is a medical oncology associate professor at Kidwai Institute of Medical. He is talking on gastrointestinal cancer. Your time allotted is 20 minutes. Try to finish within 20 minutes, Dr. Lokesh. Over to you.
Okay. My slides are visible?
Yes. Go ahead.
Yes,
Yeah.
sir. It's visible.
So thank you, Dr. Sampath. So good evening, everybody. So to continue with the second day of our updates in medical oncology, the first topic is on updates on colorectal cancers. So I'll continue with this talk for next 20 minutes. So let's see what are the updates in colorectal cancer. So the first and foremost trial is what is called the Prodigy 223 phase 3 trial. It is a unique cancer GI trial. So it is a total neoadjuvant therapy with modified FOLFIRINOX versus preoperative chemoradiation in patient with locally advanced rectal cancer. So we all know this is a Prodigy 2-3 phase 3 trial, but this is a presentation of 7-year update in advanced advanced rectal cancer. So with this background, the locally advanced rectal cancers, in 1997, we had a preoperative radiotherapy, not shown much improvement. Then since 2004, we are practicing chemoradiation as a neoadjuvant therapy for all rectal cancer. And since 2020, we have two studies, that is Rapido and Prodigy 2-3 study. So the same study that they have updated the results of 3 years of survival. So present studies, same study Prodigy 2-3 with 7 years of updated survival. So we know that the induction chemotherapy with modified FOLFIRINOX has a manageable safety profile and does not adversely affect the therapy in stage 2-3 rectal cancer. So during the follow-up, the quality of life was higher in the total neoadjuvant therapy arm, and this is the report of 7-year follow-up. This is the study design, CTRT followed by total mesorectal excision followed by 6 cycles of modified FOLFOX as a standard arm. Total neoadjuvant therapy, that is in the form of 6 cycles of modified FOLFIRINOX. It is for 3 months followed by radiation with capecitabine or 5FU, followed by total mesorectal excision followed by 6 cycles of FOLFOX, that is based on the center of treatment. So this is the eligibility criteria: T3 with high risk recurrence, that is T3 with N1 positivity or any T with or even T4 were included. So the primary endpoint is disease-free survival. This is the results at 7 years showing the local results 5.3 versus 8.1. So TNT is better at 7 years. 5 years was also same. Metastasis at 7 years, it's 20% versus 27%. So better with the total neoadjuvant therapy. So now we have a 7 years update on total neoadjuvant therapy in rectal cancer. The metastasis is 20% with TNT and 27% with standard of care. So 38% of the patient with metastatic disease still alive at the time of data cutoff. So this is the disease-free survival events. You can see all the events, the metastasis, locoregional relapse, with both or even the death and the second cancer. So maybe second cancer is little higher on the total neoadjuvant therapy because of a combination with neoadjuvant chemo and the radiation. So, but you can see the metastasis is less and also the chances of death. So all these favors total neoadjuvant therapy. What about the disease-free survival? You can see the 5% difference in 7-year DFS. And also the metastasis-free survival at 7 years, it is 8% difference, 8% better with TNT. And cancer-specific survival with respect to the rectal cancer, that is also better, 79 versus 84, 5% benefit. So it all favors the neoadjuvant, total neoadjuvant therapy. So what is this TRIS phenomena? That is if we give neoadjuvant therapy, we will give surgery. After surgery, if the patient relapses, their survival is actually very bad in the previous studies. So in this Prodigy 2-3 study, there is no reduction in survival after the distant failure in total neoadjuvant therapy arm. So this is the overall survival. The benefit was 5% at 7 years. It's actually a good benefit. So conclude, the induction chemotherapy with modified FOLFIRINOX before chemoradiotherapy improves overall survival of patients with locally advanced rectal cancer. Even it improves the disease-free and metastasis-free survival that were durable. There is no increase in local recurrences with unchanged safety profile with a similar or improved quality of life. TNT with modified FOLFIRINOX now should be considered as one of the best option of care in patients with locally advanced rectal cancers. So this strategy is now investigated in rectal cancer for tailored management according to the response to induction modified FOLFIRINOX. So that is about Prodigy 2-3 trial. It is a practice changing trial. So I think few of us already started using total neoadjuvant therapy in rectal cancer. So this study will support us to continue with total neoadjuvant therapy with 7 years update showing improvement, progression-free survival, cancer-specific survival, metastasis-free survival, and also the overall survival. So that's about Prodigy 2-3 trial. So this is also one of the practice-changing trial prospect. Many of the people have told practice-changing updating this ASCO. So what is this study? It's a pre-operative chemotherapy with selective chemoradiation. Remember, it is a selective chemoradiation versus chemoradiation for locally advanced rectal cancer, the prospect trial. So what is the summary? The most intermediate risk rectal cancer. I'll come to that. What is the intermediate risk? Most intermediate risk rectal cancer patients can receive curative intent treatment without pelvic chemoradiation. Think about patient not receiving radiation in case of rectal cancer. So of course, it is a standard of care since 2004, as I told. Now we are thinking to omit the radiation in patient with rectal cancer. So this is the usual chemoradiation, 8 weeks recovery. Then we do surgery with total mesorectal excision. Then comes adjuvant chemotherapy with Capox or Folpox. So these are the why we should avoid radiation because of its long-term toxicity. It can have a impaired bowel, bladder, and sexual function, increased risk of pelvic fractures and second malignancies, impaired marrow reserve, and also the infertility and premature menopause. So these are the complications of long-term complications of radiation. So if you avoid radiation, potentially you can prevent all these side effects. Not only that, there are advances have happened in the last 2 decades. So that is chemotherapy, the Folpox pre-operative or post-operative. Then we have total mesorectal excision has come into the treatment armamentarium. Then screening has changed. So we have fever, T4 and symptomatic tumors, and also the imaging. Now we started using pelvic MRI for most of our rectal cancer. So what is the hypothesis in this study? The neoadjuvant chemotherapy with Folpox and only selective use of pelvic chemoradiation will be non-inferior to routine use of pelvic chemoradiation for locally advanced rectal cancer. So what exactly is this? This is the summary. The neoadjuvant treatment for, see, the tumor included were T2 node positive, T3 node positive or node negative rectal cancers. They were randomized into pelvic chemoradiation, followed by surgery, followed by adjuvant chemo. That is the standard arm. Then in the experimental arm, we have 6 cycles of Folpox. The earlier Prodigy study used modified FOLFIRINOX, but this is 6 cycles of Folpox. Then you do the restaging and see for the response. If there is more than 20% response, maybe similar to partial response, what we see in RECIST criteria, then there is no role of, they'll not undergo radiation. They'll straight away go for surgery followed by adjuvant chemotherapy. If the response is less than 20% of or the patient is not tolerating Folpox, they will be taken up for pelvic radiation followed by surgery and then adjuvant chemotherapy. So this is the inclusion I told already. T2 node positive, T3 node positive or negative. Chemoradiation is whenever it is indicated, these are included, and they should be a candidate for sphincter preservation surgery. But the patients who need APR are all excluded. The primary endpoint is disease-free survival. This is the non-inferiority margin cutoff 1.29. So these are the patient characteristics. So this is the outcome in terms of disease-free survival at 5 years. You can see 80 versus 78%, not statistically significant. The curves looks similar at the median follow-up of 85 months, 58 months. So disease-free survival at 5 years is same. And the non-inferiority criteria was met with a criteria of non-inferiority. Then again, local recurrence free rate at 5 years, 98.2 versus 98.4%, similar local recurrence at 5 years. And also the overall survival at 5 years, it is similar with the median follow-up of 58 months. So, and also you can see the pathological complete response was 24 with chemoradiation and 22, almost similar with the use of FOLFOX followed by selective pelvic chemoradiation. And this is again the same with respect to use of chemotherapy. So use of pelvic chemoradiation in patients randomized to FOLFOX, only 9% of the patients randomized to FOLFOX received neoadjuvant chemoradiation. So they received radiation because it demonstrated the clinical responses is less than 20%, or they did not tolerate at least 5 cycles of FOLFOX. That is the reason for receiving radiation. So again, this is the neoadjuvant and adjuvant grades, and you can see the neoadjuvant treatment. Diarrhea was more common in the RT group, and neuropathy was more common in the FOLFOX group. But in adjuvant treatment, you can see the diarrhea and neuropathy both are more common in the RT group. So that is what it says. The diarrhea is more common in chemoradiation in neoadjuvant group with other chemotherapy-related toxicities, but neuropathy is more common in the adjuvant group in the chemoradiation followed by adjuvant group at 12 months. This is the quality of life. So the quality of life trend, but no significant difference between the groups. The bowel function, sexual function favor FOLFOX group. So the limitation is it excluded the patients with high risk disease, that is distal tumors, T4 disease, multiple enlarged nodes, and not all the patients had undergone MRI. So we may still be over-treating few patients. So the caveat is while conducting this trial, there are new approaches were emerged, that is adjuvant use of short courses of FOLFOX, short course radiation, total neoadjuvant therapy, and few non-operative managements with immunoablative therapies. So the conclusion is neoadjuvant FOLFOX with only selective use of pelvic chemoradiation is safe, effective treatment option for patient with T2 node positive, T3 node positive or negative rectal cancer. So this is a non-inferiority in non-oncological outcome was met with 2 studies. Again, with respect to neuropathy, less long-term neuropathy. But when it comes to the radiotherapy-related toxicity, the fecal incontinence, sexual dysfunction, infertility are more common in the chemoradiation with the post-op FOLFOX group. So these are the side effects you can potentially avoid if you use the neoadjuvant FOLFOX with, and you can spare the radiation. So some reflections on these results include, are we truly really locally advanced tumors were included in this study because not all the patients undergone MRI? Is neoadjuvant treatment included for all the patients included? So as a neoadjuvant treatment needed really for all the patients? That is also a question mark because T2, N0, we don't usually give chemotherapy. So what if a patient prefers organ preservation? So that is also a one thing, because organ preservation usually we go for radiation. So this is the ESMO definition of rectal tumors, early, intermediate, locally advanced, and advanced. So in the prospect study, these are the criteria I already mentioned. This is the ESMO guidelines again. So ESMO guidelines say that for intermediate risk only, usually the short course RT or chemoradiotherapy is included, even if TME cannot be assured. But NCCN recommends total neoadjuvant therapy for T1 to 3 and N1 to N2 disease. So these are several other trials, FOWARK and PRODIGE 2-3 trials, which I already discussed. So what about the difference between this prospect and FOWARK? So FOWARK, you can see the results at 10 years with similar outcome, and here again prospect a similar outcome at 5 years. So FOVARC, the local recurrences are actually high, 8 to 10%, here only 1 to 1.5%. This is because the FOVARC actually included more number of T4 and N2 disease, and there were no abdominal resection patient were included as compared to the FOVARC. And pathological complete response actually very good with the prospect. What about the PRODIGE 2, 3 to 7 years update? This is 5 years update. So you can see the non-inferiority with the similar outcomes. The PRODIGE has a more number of patients with T4 and N2 disease, and less than 5 centimeter were around 37%. So because of that, still they have achieved very good pathological complete response because of irinotecan and also the chemo radiation, long-term chemo radiation. So takeaway, FOLFOX followed by selective chemoradiotherapy can replace standard neoadjuvant chemoradiotherapy, and largest benefit is less long-term radiotherapy related toxicity and shared decision-making advised in all cases. So how would I treat my patients in clinic? So patient preferences depending on the profession or hobby. If there is a female patient in childbearing age, definitely I will go for avoiding radiation and its side effects like sexual dysfunction, bowel bladder dysfunction, and even the secondary malignancies. So I will go for prospect approach, especially also in elderly patient living far away. We can really avoid short course radiotherapy. We can go for neoadjuvant chemo followed by surgery if there is a good response. So these are the future direction. Based on this study, I think we need to have a further studies addressing the low-lying tumors, very advanced tumors when there is organ preservation, and not all the patient may need neoadjuvant chemotherapy, especially when there is an early stage. So next we have one more study, that is a Scandinavian NeoCol trial. This phase 3 randomized clinical trial comparing the efficacy of neoadjuvant chemotherapy and standard treatment in locally advanced colon cancer. This is a colon cancer study. So we all know that Foxtrot study, that is a neoadjuvant therapy in colon cancer. This is one more study. So with the same background of improving micrometastasis, reduction in tumor size, prehabilitation before surgery, and reduction in adjuvant chemotherapy, this study, the objective is to assess the impact of neoadjuvant chemotherapy on locally advanced colon cancer compared to standard upfront surgery. So this is the study design: standard upfront surgery followed by pathological staging and chemotherapy. So in other arm, it is experimental neoadjuvant chemotherapy followed by surgery, and only extra chemotherapy based on the TNM risk factor. This is the patient inclusion criteria. T3, T4 lesions are included. So arm A is standard upfront surgery. Arm B is neoadjuvant chemotherapy, which include 3 cycles of Capox or 4 cycles of FOLFOX. Then adjuvant chemotherapy in both arms are not mandatory. So patient characteristics, and you can see the number of preoperative cycles less than 3. You can see the total number of cycles the patient has received: 5.9 when the patient undergoes upfront surgery versus 4.8 in patient who undergoes neoadjuvant therapy. Because post neoadjuvant therapy, few patients they have not given the therapy because of good pathological response. So this is the, you can see even the neoadjuvant therapy, the number of laparoscopic surgeries has increased, and laparotomies have more with upfront surgery. And not only that, the ileus is a bit less in the neoadjuvant group, and also the anastomotic leak is less with the neoadjuvant treatment. So pathological nodal status achieving complete response is good with the neoadjuvant therapy, and also the vascular invasion is less as compared to the upfront surgery. So, and also the criteria for adjuvant chemotherapy fulfilled was only in 59% of the patient when you give neoadjuvant treatment versus 73% when you give chemotherapy after surgery. So toxicity, you can see the sensory neuropathy and motor neuropathy bit less in the neoadjuvant group, and also in during follow-up it is a bit less. So we all know that the patient who received neoadjuvant therapy, actually the tolerance to chemotherapy is better as compared to when given in the adjuvant setting. Efficacy outcome, disease-free survival is similar, overall survival is similar. So conclusion, neoadjuvant chemotherapy is not superior to standard upfront surgery concerning DFS and OS in patient with colon cancer. It may have a favorable outcome in number of chemotherapy cycles, risk of chemotherapy toxicity and surgical complication, and also in downstaging the tumor. This is one more study. What is the role of immunotherapy in colorectal cancer. This is the study that is going to answer the FOLFOXIRI plus bevacizumab and atezolizumab as upfront treatment in unresectable metastatic colorectal cancer. Updated and overall survival results of the phase 2 randomized atezo-tribe study. So this is the same background. The patients were randomized FOLFOXIRI plus bevacizumab versus plus or minus atezolizumab. So with the further summary, it shows that at a median follow-up of 37 months, the addition of atezolizumab to FOLFOXIRI plus bevacizumab as initial therapy confirmed the prolonged progression-free survival in molecularly unresected metastatic colorectal cancer patient. As a preliminary overall survival analysis, there was a trend, but improvement in the overall survival was observed with a better outcome in terms of both PFS and OS, also in cohort of patient with proficient MMR tumors. So, and also there is some relation with immunoscore and also the tumor mutation burden. So based on this, there is a phase 3 trial that will be launched by the sponsor with the use of atezolizumab into upfront FOLFOXIRI plus bevacizumab. So this is the last study, that is trifluridine and tipiracil with the bevacizumab. So usually when the patient in colorectal cancer, we know that they'll receive first line FOLFOX or CAPOX followed by FOLFIRI. So after that, we don't have much options. So this study actually see the use of trifluridine and tipiracil with bevacizumab, with or without bevacizumab, and it has shown that there is a 3 months overall survival, progression-free survival benefit with the use
Lokesh,
of,
you're
and also the overall survival benefit of almost 2.5 months. So among patients with refractory metastatic colorectal cancer, the treatment with trifluridine and tipiracil plus bevacizumab resulted in longer overall survival. Thank you.
Thank you, sir, for the excellent talk. And
Thanks, Lokesh. We'll take the question answers later.
Okay, fine.
Okay.
So the next talk.
Next talk is mine.
So next talk, I would like to invite Dr. Sampath Kumar. So maybe the chairperson, you can.
Rudresh is chairperson.
so Rudresh sir will join by 7. So
Okay,
Lokesh, sir,
fine.
can you
No,
do
I
the
would like
next
to
one?
invite Dr. Sampath Kumar, consultant medical oncologist at Magnum Onco Care in Bangalore. So he is going to talk on update on upper GI malignancies. Over to you, Dr. Sampath.
Thanks, Lokesh. I will share my slides.
Yeah.
You go. You take it out.
Sir, you can share it now.
You can
Okay.
share. I'm already.
Yeah,
Okay,
it's
thank
there.
you.
Just make it full screen, sir.
Good. I'll do it. How to make it a full screen? Yes, ma'am.
Yeah, it's visible.
Okay. Outside, I thanks Dr. Lokesh and team to give this opportunity. Today, 6 studies. I'll take maybe 3 to 4 minutes per studies. First one is Attraction 5 trial. This is a phase 3 study of nivolumab plus chemotherapy as a post-operative adjuvant treatment for pathologically stage 3 gastric and gastroesophageal junction tumor. We all know, even though we have adjuvant treatment for the gastric and gastroesophageal junction, our satisfactory survival we are not seeing in our day-to-day practices. That may be the reason we are adding the immuno-oncology to this treatment. Next slide. The standard of treatment, we all know it's it's almost, we can't say it's a difference between Western and Asian. We also follow the almost same guidelines like a Western people. Once we did a D2 and extended gastrectomy, we do a chemotherapy perioperatively. But nivolumab plus chemotherapy or nivolumab monotherapy has shown a clinical benefit in advanced and recurrent gastroesophageal junction as per the Attraction 4 trial. It is also expected the efficacy of nivolumab is seen in advanced setting may be observed with post-operative adjuvant therapy for a gastric and gastro-GE junction tumors. Okay, next slide. This is the study's design. Phase 3, double-blind, placebo-controlled. It is done mainly in the Asian patients, Japan, Korea, Taiwan, and China. See, they have taken properly their key eligibility stage 3, T2 and extended gastrectomy, and the performance status is good. And they have analyzed PDL1 analysis, but they are not, when they are selecting the patients, they are not selected depending on the PDL1. So investigation of choice of adjuvant chemotherapy, they depend on S1 and Capox. In India, we use a lot of Folfox or Capox, whereas in Japan, Korea, Taiwan, they use a lot of S1 Tegonet or Tego-S people along with oxaliplatin plus or minus. They are the standard of care. We have to see that how it is work. See, sample size is quite good, 700 patient. It's almost done a recruitment for a 2 years, February 2007 to August 2019. See, they have taken a nivolumab 360 mg every 3 weeks plus chemotherapy versus chemotherapy only. Primary endpoint, relapse-free survival. It is independent review analysis. Secondary endpoint was again overall survival and safety. See, overall survival they have taken here, that we have to appreciate them. Okay. See, look at this. This is a Kaplan-Meier curve. Nivolumab plus chemotherapy versus chemotherapy alone. See, the difference of 3-year relapse-free survival rate is 68.4 versus 65.3. And the statistically significant, we cannot accept this. But anyway, any 1,000 miles of walk starts with a single step. Anyway, they have done this study to improve the relapse-free survival. We have to accept this. When you look at this, this is the forest plot curve. See, except upper GI malignancy, means GE junction tumor or a fundus tumor and intestinal type tumors, all are benefited. Even more benefit seen with a PDL1 expression patients. And the chemotherapy regimen, S1 or Capox, it doesn't matter. So it says upper gastric, gastroesophageal junction and gastric fundus tumor are still more aggressive. We have to look more carefully. What we learned from this study is this one. Secondary endpoint was, as per the investigator, we see it, relapse-free survival was 64.9 and 59.3 in a chemotherapy alone arm. But the p-value was not significant, may not be given here. And if you look at this in overall survival benefit, 81.5 and 78. Okay, 3 months, but still we have to take this one, we have to move on. Next slide. This is the serious adverse effects. If you look at the nivolumab and placebo chemotherapy, serious adverse effects are more often seen in nivolumab arm. And treatment discontinuation also more often seen in the nivolumab arm. And then endocrine related, immunological related side effects are more often seen in the nivolumab. We all know that hypothyroidism and diarrhea, transaminitis and interstitial pneumonitis, autoimmune nephritis, skin reactions are more often seen in nivolumab patients. So attraction summary, attraction 5. Phase 3 study that compared adjuvant nivolumab plus chemotherapy with placebo plus chemotherapy in patients with the stage 3 gastric and gastroesophageal junction did not meet the primary endpoint of relapse-free survival. Safety of nivolumab plus chemotherapy was considered with a known safety profile of nivolumab and each adjuvant chemotherapy. Further analysis are necessary to understand the outcome of attraction 5 trial. Relatively favorable results were observed in some groups. Takeaways from attraction 5 is adjuvant nivolumab did not improve the overall survival. So it mirrors the absent survival benefit for M1 in attraction 4 trial. Single agent checkpoint inhibitor may not be sufficient. Can we use alternative IT agents? That is still we have to see. Or the combination of two, like nivolumab plus ipilimumab, will benefit, that we have to see. And target subsets with the new agents. If the HER2 is positive, can we add a HER2 and we'll get a benefit? We have to see. FGFR, adding FGFR like bevacizumab, we have to see it. Claudin 18.2 blocker is there now. It's Jabutumax. chimeric monoclonal antibody we have to see. So tumor proportion score, positive patients benefit 14%. 60 to 80% of tumor positive negative proportion score negative or CPS positive. So outcome of CPS positive and MSI is highly awaited. Take away from attraction. Checkmate 577 adjuvant nivolumab benefit tumor proportion score patient positive and negative. Later treatment with nivolumab was better than earlier therapy. That's what they say. Will pre-op earlier checkpoint inhibitor will be better? That we have to see with the keynote and Matheron studies. The trials are still pending. So attraction 5 trials, still we need a larger data to say it is a overall benefit will is there or not. So I'll go to the second study. It's called a GLOW study. It is a locally advanced metastatic gastric and gastroesophageal junction tumor, which are unresectable. Here they are adding capox plus or minus zolbetuximab. What is zolbetuximab? It is a chimeric monoclonal antibody. It targets the pathway of CLD1 18.2, induces antibody cytotoxicity and complement dependent cytotoxicity. We all know in the spotlight study, zolbetuximab but modified FOLFIRINOX 6 improved the survival benefit in these patients, because they have seen the benefit in a modified FOLFOX 6, but now they are seeing with a zolbetuximab with capox. That is the simplest, if you say. See, this is the key eligibility criteria and the graphical presentation. They have done it in 18 countries across Asia, Europe, America, and South America also. Previously untreated, locally advanced, unresectable, or metastatic they have taken, and CLD1 18.2 should be there. Most probably this is done with a IHC, and then should be more than 75% of the tumor cells should be positive. This is the very catch, and I don't know how we are doing it in India, that we have to check it out. HER2 should be negative and performance status should be good. That is the one thing. And here what they did, zolbetuximab 800 to 600 mg per meter square plus capox in the 1 hour, and the second arm they have done only capox. They have given almost cycle 9s are they are given. Crossover is not done here in this study. Crossover study was not done. Primary endpoint was PFS, secondary endpoint was overall survival, and secondary endpoints again, key secondary endpoints was overall survival, but secondary endpoint was overall response rate and duration of response. That is, we have to put. So this is the Kaplan-Meier curve. See, if you see this lines are separating most of the follow-up. That we have to keep it in mind. So p-value is also very significant, and median PFS is 8.21 and 6.8. Proxy maximum maybe 2 months survival benefit extra, PFS benefit. This is the overall survival benefit. See, overall survival just above the 2 months survival compared to zolbetuximab arm compared to the capox only arm. So conclusion, zolbetuximab and capox showed a statistically significant and meaningful survival benefit. PFS OS benefit were sustained at 24 months. Patient continued to be followed for survival. And it's a tolerable and a manageable safety profile. Nausea and vomiting were the most frequent treatment evaluated adverse events. Initiate onset occurred mostly in the first cycle, but later we can manage without any problem. In the zolbetuximab arm, nausea and vomiting were more common in patients without a prior gastrectomy. That is palliative gastrectomy, what we mean to say. Efficacy and safety results were consistent with those observed with the spotlight. GLOW confirms the zolbetuximab chemotherapy is a new potential standard of care for patients who are expressing the CLDN 18.2 positive, HER2 should be negative. This is what we learned from this study. So I'll go to the third study, that is a perioperative PD-1 antibody blocker called toripalimab plus SOX or Zelox. So most of these SOX or Zelox treatment, we know it's used in Japan, Korea, and this is the country they use. So this is the periodic chemotherapy standard of care for a patient with locally advanced gastric and gastroesophageal junction. We all know prognosis with local advanced is still unsatisfactory. We all know that is not so good one. Standard first-line chemotherapy and anti-PD-1 or PD-L1 had demonstrated superior survival for advanced and metastatic gastric. Why this study? Because the blocking the PD-1 and PD-L1 happened with in a metastatic setting. That may be the reason they included in the adjuvant. We present the addition of PD-1 antibody toripalimab in to periodic chemotherapy. This is randomized open-label phase 2 trial that we had to do. Histologically confirmed T3, T4 with nodal and resectable disease they have taken. They have taken equal number, 54, 54. Toripalimab plus SOX can be given as a neoadjuvant, 3 cycles, surgery followed 5 more cycles. Here, in one more arm, they are not included toripalimab, which is a PD-1 blocker. They have given only the SOX and Xalox in these patients. So this is the tumor regression grade. They have taken 0 to 3. Poor response is a 3 and good response 0. So we'll see how much. PD-1 antibody toripalimab plus chemotherapy increase the proportion of locally advanced gastric and GE junction cancer patients achieving tumor response grade 0 to 1, 20 to 44 patient. Maybe 44% is a very good number of with a statistical significance. So addition of toripalimab had an acceptable safety profile. There was a no new safety signal. That is very important. No new safety signal. So these data support the exploration of anti-PD-1 plus chemotherapy in phase 3 trial. But we have to see how it is. So fourth study is one of the maybe practice changing. All those are practice changing. Nalari-Fox versus nab-paclitaxel gemcitabine. We all know metastatic poorly differentiated adenocarcinoma is tough to get a benefit out of it. So here we have done a Napoli, they have done a Napoli study, but this study done across all the advanced countries like US, Germany, Hungary, all the things. If you look at this, they have taken Canada, US, Brazil, Australia, and then the strength of the study is also very good. So we have to keep it in mind. Here, what is that? Instead of FOLFIRINOX, they use the FOLFIRINOX regimen, but they've given a liposomal irinotecan. Liposomal irinotecan, what they used a very less dose, toxicity profile will be low. Liposomal, you know, no plasma of life will increase, and then time under the curve will be increased, and the therapeutic benefit, and then cytotoxicity to the cytotoxicity also will increase if you add a liposomal irinotecan. Here, all the patients are metastatic, and then all measurable one, they have taken these patients. One are liposomal irinotecan, 5-FU leucovorin, oxaliplatin, FOLFIRINOX, but it is replaced with liposomal. That's called Nalarirox. It's called. It's very tough to pronunciate. Napoli trial, Nalarifox instead of FOLFIRINOX, Nalarifox. Then one more arm is GEM and nab-paclitaxel, as we see. Look at this, the study endpoints and statistical design they have done. Overall survival, PFS, and secondary endpoints, health-related quality of life, biomarker assessment. These are all the first patient enrolled was February 2020. The last were July 23 to 2022. So overall, median follow-up of 16.1 months. That's a good. So this is the thing. In the median overall survival, if you look at 12 months, it's a 45.6 versus 26 versus 39.5 in a GEM nab-paclitaxel. Whereas at 18 months, it's still more good, 26.2 and 19.3 months. This is what we've seen in these patients. Say, look at this forest plot curve. All across all the subgroups, this is going to helpful. That we had to it going to be practice changing in India. And then PFS, as per the investigator intention to treat analysis, also Nalarifox was superior to the GEM and nab-paclitaxel. This is what the study says. And this is study done in across the globe. See, this is the forest plot curve, all across it is benefited. Or whatever may be the this one metastatic number of mets, it is benefited. Presence of fever metastasis, it is benefited. Whatever ECOG performance status also is benefited well. So we could not find anything. See, the complete response may be 0.3%, but partial response is 41.5 versus 35.9%. The stable disease also almost same, 25.8, 26.1%. But progressive, see the progressive disease, we all know pancreatic disease is a very tough to get a control over, especially in a palliative setting. This is what we see. Duration of response 7.3 months is 5 months. But this is, remember, this is only 16 months of evaluation. If you evaluate it later on, we may get a still more good numbers. Maybe. So treatment valuable adverse events like gastric side effects and tumor-related adverse events are almost equally in both the arms, and the NALIRIFOX arm still better compared to the gem-nab-paclitaxel. And then hematological toxicity often more often seen in the gem-nab-paclitaxel arm, whereas non-hematological like diarrhea, nausea, vomiting are often seen in. We all know irinotecan causes all GI symptoms, and neuropathy symptoms are more often little in the NALIRIFOX arm. This is advisable. We have to keep it in mind because we are giving the benefit at the cost of toxicity. Conclusion: NALIRIFOX dermatitis acting is significant clinically meaningful improvements in median OS and PFS compared to the gem-nab-paclitaxel. 18 and 12 months survival favored NALIRIFOX over gem-nab-paclitaxel. OS and PFS across all subgroups, we know. NALIRIFOX is a manageable, consistent with the profiles of treatment components. No new safety concerns with the NALIRIFOX regimen are identified. These results support the NALIRIFOX a new reference regimen for the first-line treatment patient with metastatic pancreatic ductal adenocarcinoma. One plus side of Napoli 3. We had previously seen relying on cross-study comparisons, the relative merits of we can use FOLFIRINOX instead of NALIRIFOX. That is a debate. The study finally provides level 1 evidence head-to-head comparison, international court of mixed practice setting, statistically significant improvement of this particular regimen over gemcitabine nab-paclitaxel. Definitely FOLFIRINOX is better, but if you compare FOLFIRINOX versus NALFIRINOX, that we don't know which one to choose. NALFIRINOX and FOLFIRINOX both are looking good, but median PFS is better in NALFIRINOX, 1 month extra. Overall response rate is also better, and then grade 3-4 cytotoxic neutropenia and diarrhea is also more in the
last 5 minutes.
Okay, NALIRIFOX arm. About only issue is liposomal irinotecan is very expensive. That I don't know. In India, it may be less because we have a lot of generic things. Napoli implications of clinical practice. With this data, gem-nab-paclitaxel should be more consistently as a second line. So first line, you can go with a NALIRIFOX. If you don't, FOLFIRINOX. So does NALIRIFOX replaces FOLFIRINOX as a first line treatment? That I think I can say yes, because lower doses of oxaliplatin, lower doses of irinotecan, but yes, at the cost of little toxicity, GI toxicity. Do you have still know about NALIRIFOX quality of life, biomarker, cost effectiveness that we have to? Future implications in trial design. Does NALIRIFOX need to become a control arm in randomized first line trials? That we have to see. This one we have leave it. This is an NORPACT exploring the role of neoadjuvant FOLFIRINOX for resectable pancreatic cancer. Say we all know neoadjuvant chemotherapy for pancreatic is increasing over time, but potentially resectable is a very fuzzy term. We don't know which is according to some. We depend upon the surgeons or the intervention radiologist. Is it resectable or not resectable? We don't know about the clear cut what to do. That's the reason they have done a FOLFIRINOX, the NORPACT study. See, they have done in 2 arms. NORPACT potentially resectable upfront surgery and then 12 cycles of FOLFIRINOX. Neoadjuvant in one more arm, neoadjuvant FOLFIRINOX 4 cycles surgery and then again 8 cycles. See, look at this. Median overall survival 25.1 versus 38.5 months. in a neoadjuvant arm. See, this is the things they have randomized 77%, 63%. The survival and only half of patients assigned to a neoadjuvant FOLFIRINOX ended up completing 4 cycles. So if you look at the data again, say, so if you use neoadjuvant FOLFIRINOX, R0 resection will increase by 56%, almost 30% more than the upfront surgery arm. N0 resection also will increase. So this is also the modified FOLFIRINOX. Why did so many patients receive off protocol adjuvant treatment? We don't know that one. We have to keep it in mind. So author's conclusion: results do not support the neoadjuvant FOLFIRINOX standard of care in resectable pancreas. But if you anything is unresectable or borderline resectable or doubtful resectable, plus better to push them for the neoadjuvant FOLFIRINOX is very much still out. And then two more studies, Alliance and pre-op, also will guide about our treatment. The last study, see, we all know HCC, we don't have a adjuvant treatment. In this, they have in IM Bravo 50 trial, they included atezolizumab, bevacizumab as a adjuvant treatment versus active surveillance. This is done across in Japan and these China countries only. See, this is atezolizumab, bevacizumab. Earlier is very important. High risk recurrence rates, they are taken only high risk recurrence. What is high risk recurrence? Tumor which is more than 5 centimeter or more than 3 tumors. Microvascular invasion should be there. Minor microvascular, VP1 or VP2. VP1 means portal vein invasion, right and left portal vein invasion. VP1, VP2, they think. Grade 3, grade 4 pathology, they have taken this one. They have active surveillance, they are doing. They have done almost 12 months of cycles, and then crossover is also advisable in this study, permitted. So results is not out, but what is there in IM Bravo 50 is a first positive phase 3 study in HCC to demonstrate the relapse-free survival improvement with the adjuvant treatment following curative intent resection or ablation patients. The safety profile was generally manageable considering that of each of agent with the underlying disease. Okay. Health-related quality of life, a functioning score between and atezolizumab and bevacizumab versus active surveillance were comparable throughout the treatment. It is a practice-changing adjuvant treatment option for patients with high-risk HCC. Thank you.
So thank you, Dr. Sampath, for a wonderful talk. So
Thanks, man.
I think as per this, I think adjuvant nivolumab is out of the question now. Now we have a new target, Claudine, coming into the
Yes.
targeted therapy management in the gastric cancer. Again, the toripalimab, the immunotherapy. And the most awaited is NALIRIFOX, that is versus
NALIRIFOX, that's what. Liposomal irinotecan. Liposomal irinotecan, if it's available in India in a generic company, I think we can do that.
Yeah, we are all using modified FOLFIRINOX. So NALIRIFOX is nothing but changing irinotecan to liposomal irinotecan.
So dosage will be less.
Long time expected the results. So I think that will give you an answer, and that shows that the NALIRIFOX is the better as compared to the gem-nab-paclitaxel in metastatic pancreatic
first line treatment. Yes.
Yeah, that is the one practice changing update. So once the liposomal irinotecan is available, I think that will change our
practice.
Practice. Meantime, I think we can take it as a modified FOLFIRINOX is also a good option, and maybe the outcome we don't know really similar or better than gem-nab-paclitaxel. Okay, thank you for your wonderful
talk.
Lokesh. So now I would like to invite Dr. Rajiv LK, Associate Professor, Department of Medical Oncology, Kidwai Cancer Institute. He's going to talk on newer management in the newer updates in the management of first-line biliary tract cancer, and this session is sponsored by AstraZeneca. So over to Dr. Rajiv.
Good evening, Rajiv sir.
Thank you, Lokesh, for your kind words. Good evening, all. Can I share my slide?
Yes.
Hope the slides are visible.
Yes.
Go ahead.
Okay. So another 20 minutes, I will be talking about biliary tract cancer. The first one, I will be updating the management of first line. So this is from the AstraZeneca, and I thank Satish and Lokesh for giving me this opportunity. So what is BVR? So biliary tract cancer. Statistically, we know almost 31,000 odd biliary cancer was diagnosed as per the National Cancer Registry. The crude incidence, again, it favors more in females. 90% of the biliary tract cancers which are diagnosed will be unresectable or advanced. So what we are seeing as a standard of care, gemcitabine cisplatin, the median OS is below 1 year. We are not crossing 1 year, and the 5 years OS rate is below 10%. Now, this is a very detrimental outcome. So, and what we are seeing in the present, there will be an increase in the incidence of this biliary tract cancer in both the sexes. You can see the graph in both the sexes, there is an increment. What is the current standard of management? So in 2010, we all know gemcitabine plus cisplatin, it was established. What we had the benefit was, so median OS of 11.7 months versus 8 months. So this was the benefit we got with the first line treatment, gemcitabine with cisplatin. And if you see the PFS, it is 8 months versus 5 months. So as for this study, the GemCis became the standard of care. Till now, there were no good study supporting or improving the survival. So gemcitabine versus cisplatin and gemcitabine versus hexalplatin doublet, they see both the platinums. So you can see the graphs, they are all non-inferior. So what we have concluded with this comparative, they will be gemcitabine cisplatin or gemcitabine if you replace with hexalplatin as an initial treatment, they had a higher event-free survival, potentially at lower cost. So what we are seeing, lower incidence of peripheral neuropathy and hepatotoxicity with the GemCis, and lower incidence of hematological toxicity what's seen in GEM-oxaliplatin. So this is only the toxicity difference we have seen. The outcome difference is almost same. It was not statistically significant. So what is the treatment option? So you can see the NCCN guidelines the last year. The preferred regimen is GemCis in the category 1. So there are other options now become the second options. So coming to the immunotherapy in first line biliary tract cancer, this is the Topaz 1 study done by the AstraZeneca. This is the phase 3 randomized double-blind placebo control. What they have done, they added for the standard of care, gemcitabine cisplatin, they added durvalumab. So this was the study. They have taken up phase 3 study. 3 weekly, they gave durvalumab along with the standard of care, and durva is continued once they have completed 8 cycle until progression. What they looked, it was a 1:1 randomization. The primary objective was to overall survival. They have different secondary objectives. So if you see the profile of demography, it was well matched. So most the Asian, whites, and other population is also included. And if you see the primary tube, it is intra or extra, both are, even the gallbladder cancers were also there. And they included initially unresectable cases also, and they have included recurrent cases. So even though 20% were recurrent cases, and most of them are metastatic, almost 90% were metastatic. Coming to the MSI status, again, you can see there were many are missing, 50% were missing. And if you see the viral markers also, they have some had hepatitis B. And they did the PD-L1 expression also, almost 30%. You can see tumor area positivity was below 1% and above 1% was also started. Coming to the ongoing disease control role. This is one good thing in the study on almost you can see the 19% of the patients were still ongoing disease control. I mean, at the date of cutoff, they are all ongoing treatment. Coming to the results at 2 years, you can see the Kaplan-Meier curve. It has a significant benefit at all the intervals. At 2 years, you can see 11.5% benefit. That is 24-month overall survival. Coming to the OS benefit favoring the durvalumab, you can see the forest plot. So it has benefited almost all the subsets. So even if they are male or female, or the age, or if you see the PDL expression, or if the patient is intrahepatic or extrahepatic, all the subset, Asian versus non-Asian, and even locally advanced versus metastatic, all the subset they favor the with the steady arm, that is Durva, adding Durva. So what we have seen with this Kaplan-Meier curve, you can see the disease progression-free survival at 12 months, it was almost 16% versus 6.6%. So they are wide apart. You can see, as this is a rare cancer, so we don't see a much benefit with this subset of cancer. So the Durva has done a good job. So you can see the PFS with the forest plot. So again, it favors the steady arm, that is a Durva arm. You can see same sex, age, and you can see the PDL1 expression also, along with the Asian versus non-Asian also. Even the biliary tract, locally advanced versus metastatic, all the subset, the steady arm favors the molecule. So coming to the superiority over this overall response, you can see the response rates were 18 versus 24.6%. And the duration of response also, you can see the 6.4, there was a beneficial effect in the duration of response also. At more than 12 months, almost 26.1% of the patients versus 15 were still ongoing with the response. Coming to the patient who responded, what we see with this Kaplan-Meier, the patient who responded, he is going to respond. You see the top curve, this is the patient who had CR or PR with the steady arm, they continue to respond. The next one was the CR or PR with placebo. So suddenly there will be gap. So when the patient responds with Durva, what we can see is, you can see they continue to respond. And the same thing you can see, even the subset of stable disease also, the steady arm benefited. So here you can see the steady arm, there is a benefit. So even if it is a stable disease, there is a response to the molecule. Coming to the safety profile, you can see, as expected, you can expect a adverse event with the steady arm. It was almost comparable. So we know well how to manage immunotherapy. You can manage these things. Coming to the most of the common adverse events which are related are chemotherapy. You can see any adverse events, they are more with the chemotherapy. As expected, you can see some immunotherapy related complications were more with the immunotherapy arm. But grade 3, grade 4 were less with the steady arm. Coming to the other most common grade 3, grade 4 toxicity, the bar diagram explains, they're more with the steady, with the chemotherapy arm, but the Durva arm, there is a lesser compared to the standard of care. Coming to the low grade toxicities, again, they are comparable and they are not different with the control arm. So OS for Durva, comparing with the participants, you can see the durvalumab along with the chemotherapy is associated with the OS benefit compared and irrespective of the adverse event occurrence. So NCCN guidelines in this year, you can see they added Durva and gemcitabine in the category 1 after gemcitabine. So durvalumab has given a category 1 recommendation in this subset of cancers. So what is new in this era? So we are well known in the last decade, it was gemcitabine plus cisplatin. So durvalumab plus or minus tremelimumab, as tremelimumab is not available, so durva plus gemcitabine cisplatin, according to the TOPA scale, in this year, it is a treatment of choice. So I conclude this study with overall survival. There is a benefit with adding durvalumab. As a biomarker, they have seen effective across all the molecular things. And coming to the safety, they did not add any additional toxicity. So even in India, DGCI approved this molecule along with the chemotherapy. So this is the first global phase 3 trial. It supports positive result with immunotherapy in a biliary tract cancer, and this could become a new standard of care. So moving on to this year, last week, what happened in ASCO, I will be presenting another 2 studies in this subset. So this is one, keynote 966. What I'm speaking is the quality of life outcome. This was presented in the last week. Here they have seen the pembro with chemotherapy in the advanced biliary tract. So the study was this study was published. I'm only presenting this quality of life thing. So health-related quality of life is a critical consideration. The primary analysis of this study, the pembrolizumab in the first line. Again, they have seen with gemcitabine and cisplatin demonstrated a statistically significant OS. This is around 12.7 months versus 10.1%, 10.9 months. So with 17% benefit, with significant p-value. And safety, again, it is similar between the study arm and the comparable arm. So as expected, grade 3 AEs were 69% to 70% in each arm. The current analysis, what they have presented in last ASCO, was health-related quality of life. So what they have seen, you can see the randomized, it is a 1:1 randomization with the pembrolizumab plus chemotherapy. Primary endpoint was OS and secondary endpoint was PFS. They had a pre-specified exploratory arm of this quality of life, health-related quality of life analysis. What is the inference? They had a questions. So they concluded that in the combination with previous keynote 966 efficacy and safety data, they support the use of pembrolizumab plus chemotherapy as a first-line treatment. Coming to the next update, again, it was presented in the last ASCO. Here they are seeing with the tucatinib and trastuzumab, that is HER2. This is one of the HER2 positive tumor. They have seen the anti-HER2 therapy in this subset. So what the background? The most BTCs have advanced disease at the diagnosis. The standard of care, again, it is a gemcitabine plus cisplatin plus or minus immunotherapy. Durva has also come into the picture. Second line options are limited. So what they have seen, there is almost 20% of these cancers have HER2 overexpressed or amplified. They wanted to see the anti-HER2 therapy in these subset. So tucatinib, this is the oral TKI, and selectively approved by FDA in the combination of capecitabine, trastuzumab in the metastatic HER2 breast cancer, and also in trastuzumab and RAS wild type in the colon cancer. This is approved in those indications. They wanted to see in this indication. So again, they had a cohort. It is a phase 2 study. The patient with unresectable, locally advanced or metastatic biliary tract HER2 overexpression or amplification, as per the local testing, it may be IHC or NGS, with a measurable disease. At least one prior systemic therapy they have taken. They have made tucatinib 300 milligram. It is oral twice a day. And trastuzumab, as it is given in the other setting, 8 milligram loading dose with 6 milligram in the following doses, once in 3 weeks for 21 day cycles. So here what they have seen primary endpoint was overall response rate and secondary endpoint disease control rate or duration of response in PFS. In the analysis, what they have seen, the median duration of response was 6 months and with the disease control rate of 76.7% with this study. So tucatinib and trastuzumab had a tolerable safety profile, no AE related deaths. There was only 3.3% of the patient discontinued the treatment due to AEs. And the exploratory analysis suggests what HER2 testing by any method is used in this study, and investigators concluded that the results provide additional validation for HER2 as an actionable biomarker in the biliary tract cancer. And one more study, again, this was presented in the last ASCO, Horizon. Here they looked into the bispecific HER2 targeted therapy and previously treated HER2 amplified biliary tract cancer. That is ERISA. So what they have seen is overall response rate was 5 to 15% and median PFS of 4 months. And a subset of HER2 amplification and overexpression, they improved the survival with a favorable response rate. Currently, there are no HER2 targeted as approved in the biliary tract. So they wanted to see this zanidatamab is a HER2 targeted bispecific antibody which binds to HER2 epitopes, resulting in multiple mechanisms of action. The current analysis reports efficacy and safety. Zanidatamab is previously treated in HER2 amplified or locally advanced unresectable metastatic biliary tract tumor. This is a phase 2 Horizon study, BTC-01 trial. So it is an open label stage 2B study. They had a 2 cohort. What they did, the IHC 2 plus or 3 plus or HER2 positive in a 1 cohort.
Last 2 minutes.
IHC 0 or 1%. So they used 20 milligram per kg to 2 weekly for 28 cycles. So, and what they see, they had an overall response rate of 41.3% with median duration of response was 12.9 months. And about the safety profile, few treatment discontinuation. There are no treatment related AEs, grade 4 AEs. So investigation concluded that this result supports evaluation of zanidatamab as a potential treatment option in this subset of cancer. Thank you for patiently listening.
Yeah, thank you, Dr. Raju, for excellent talk. So, any questions? I think HER2 we are not doing routinely for our all patients with biliary tract cancer. Maybe we should start doing for our patient. At least we have trastuzumab available and lapatinib available. So with that, I think we can use and see what is the response in our setting.
As it is used in other HER2 positive cancers, breast, colon, and lung. So as a precision medicine, wherever the targetable molecules are there, we can definitely use and explore the options. Especially these subset, we don't have a good options. What to say, there are many good options in these subsets. So we can explore these options as molecules are available.
Yeah, all these drugs are not available to tucatinib and even other molecules.
Trastuzumab is available.
Only trastuzumab and lapatinib we have. And TDM1 still we don't know what is the benefit or data. So fine. Thank you very much, Dr. Rajiv.
Thank you, Rajiv sir.
So I think now we'll close this session. Next session is on hematology. So that session will be chaired by Dr. Mahesh Aur. He's a senior consultant hematologist and bone marrow transplant physician from Sparsh Hospital, Bangalore. So over to Dr. Mahesh.
Thank you, Dr. Lokesh, for inviting me for this wonderful update series. I would like to welcome Dr. Tamojit Chaudhary, who has been part of these updates very often. And he did his DM from DM Medical Oncology from Kidwai, and I think he's a senior consultant medical oncologist at Meherbai Tata Memorial Hospital, Jamshedpur. I think every day is a change in the field of lymphoma and multiple myeloma. A lot of new drugs, lot of therapeutic armamentarium coming into the treatment of lymphoma and myeloma. So let us hear from what Dr. Tamojit has to say from the recent updates which have been happening in the field of myeloma and lymphoma. Over to you, Dr. Tamojit.
Thank you. Good evening, sir. So I'm trying to share my screen, but it's showing that you cannot start while other participants is sharing. So just a minute.
Nobody is sharing, right? Yeah.
Dr.
Yeah, just a minute, sir.
Okay.
Yes, sir.
Hope my slides are visible.
Yes.
sir.
We can enlarge it. Yeah.
Yeah, just a minute, sir.
Tamojit, if you want, the supporting team will present the slides.
No, sir, I'm just making it a slide share view. Just a minute, sir.
We can see the slides. Only thing is just enlarge it. That's all.
Make it as a full
Yes,
screen.
yes. Yeah.
Yeah, I believe
Yes.
it's done.
Done,
Yeah.
done.
Thank you, sir. Yeah. So good evening to all, and thanks for this opportunity. Thanks to Lokesh sir and, for this opportunity, and thanks to the chairperson, sir. So I believe it's a very difficult task to cover up all the hematological updates in the next 30 minutes, but I'll try to share the important updates, predominantly the updates which can have potential therapeutic changes or potential change in our current practice, predominantly for Hodgkin lymphoma and for multiple myeloma and for low risk MDS. So other studies are predominantly phase 1, phase 2, but we'll try to touch upon them as well. So the first data is a SWOG study. It's a very landmark randomized trial, phase 3 trial of Nivo ABD versus brentuximab ABD for newly diagnosed advanced classic Hodgkin lymphoma. So we are all aware about the Echelon-1 data, which is a phase 3 data, and the 6-year overall survival data has been published just previous year in 2022, which has supported the category 1 recommendation for brentuximab vedotin plus ABD over and above ABD regimen in advanced classic Hodgkin lymphoma. Keeping in mind there is a 6-year overall survival benefit of in the range of 5%. So we all know about the data, as well as there was EFS benefit in the pediatric population also. But the problem is the outcomes could still be improved in the form of that the relapse remains common, 7 to 20% relapse even with brentuximab addition at 5 years. Increased toxicity with brentuximab-based regimens, predominantly in the form of peripheral sensory neuropathies, as well as neutropenia and sepsis, as well as most adolescents and young adults still receive consolidative RT in the brentuximab arm in the range of 50 to 60%, which has a potential to increase the late toxicities. Now, we all know that nivolumab is highly effective with a 70% overall response rate in the relapse refractory classic Hodgkin lymphoma, and also we have data in the frontline setting. So this phase 3 data actually is a 1:1 head-on comparison between Nivo ABD versus brentuximab ABD in patients with newly diagnosed advanced classic Hodgkin lymphoma. So it's a phase 3 randomized study. Pediatric patients above 12 years of age included, and all adults and adolescent and young adults have been included with the stage 3-4 disease with a good organ function, and the patients with ILD, pneumonitis, active autoimmune disease, or significant neuropathy have been excluded as a contraindication to immunotherapy or as a contraindication to brentuximab. Standard dose nivolumab, 240 mg fixed dose for adults and 3 mg per kg every 2 weekly dose for pediatric population along with ABD. Brentuximab, the dose used was 1.2 mg per kg every 14 days. So along with the optional post chemotherapy radiation as per the Lugano criteria, which is more than 1 centimeter extranodal disease, which is PET positive, and more than 2.5 centimeter nodal disease, which is PET positive. Primary endpoint was PFS. Around 1/4 population were pediatric age group, and about 70% of the patients having a low Hassen-Clever score with predominant Caucasians and males, and stage 4 disease around 60%. So the primary endpoint at 1 year of follow-up, although it's a very early data, but still it is 8% incremental benefit. The delta was 8%, favoring the Nivo arm with a hazard ratio of 0.48. This forest plot clearly signifies that almost all the pre-decided subgroups, the age, different IPS scoring, stage, and presence or absence of B symptoms, favoring the Nivo arm. The predominant secondary endpoints in the form of event-free survival also suggestive of benefit with Nivo, and overall survival data is still very much immature. Regarding the toxicity, although numerically neutropenia and lymphopenia are higher in the Nivo arm, but we should keep in mind that in the brentuximab arm of this trial, the primary prophylactic GCSF was mandatory, and 98% patients received primary prophylactic GCSF, but Nivo arm it was optional, and only 50% patients received prophylactic GCSF. So that again signifies the increased risk of neutropenia and lymphopenia in the Nivo arm. So regarding the other adverse events of special interest, the predominant toxicity is myelosuppression in the Nivo arm, but as we have discussed, it can be quite explained by the fact that primary prophylaxis GCSF was optional for the Nivo arm. But what is more significant is that in spite of having a low neutropenia, the sepsis rate is almost similar between Nivo and brentuximab arm. Regarding the immune-related side effects, which is of predominant importance for a immunotherapy drug, these are predominantly low-grade and including thyroid abnormalities or pneumonitis and colitis in very rare situations. And what is the main side effect of brentuximab, as shown in the Echelon 1, is also again highlighted in this trial that there is a significant proportion of grade 3/4 peripheral cerebral neuropathy in the brentuximab arm. So in conclusion, this analysis of adult and pediatric population with newly diagnosed advanced Hodgkin lymphoma with Nivo ABD significantly improved the primary endpoint, which is the PFS, as well as event-free survival, which is the secondary endpoint. And it has poised to become a new standard of care for patients with advanced stage classic Hodgkin lymphoma. Probably the mature results will come after 3 or 4 years of further follow-up. The next trial is again a phase 2 data of Keynote 667. It's basically the role of incorporation of anti-PD-1 drug pembrolizumab in high-risk classic Hodgkin lymphoma in the children and adolescent young adult oncology group after a poor response to initial 2 cycle of chemotherapy OEPA regimen. And so, as you know, that children and adolescent young adult patients with classic Hodgkin lymphoma and ACR, which stand for slow early response to initial chemotherapy, they have a very high risk for relapse. And we can use reduction or dose intensification of chemotherapy, but that can increase the lead toxicities. So probably the best way forward is tailoring therapy as per early response. Keynote 667, this is evaluating the efficacy and safety of addition of pembro over a high-risk chemotherapy regimen in children and adolescent young adults with classic Hodgkin lymphoma. So interim analysis already published, and this is an extended follow-up data. So I'm not going into the details of this design, but predominantly will focus on the high-risk population, which included anything with a stage 2B, along with or without bulky disease with a good performance score. And patients after 2 cycles of initial induction with OEPA regimen, which is the standard regimen for pediatric population classic Hodgkin lymphoma, with a PET-CT response assessment with a PET positive rate, who are ready to have a slow early response or PET positive status, that have been incorporated with the pembrolizumab along with COBDAC 28 regimen into 4 cycles. Pembrolizumab has been given with the 3 cycles. And at the end of this consolidation, if PET positivity was there, then additional radiation is given. All patients with slow early response receive pembrolizumab maintenance. Primary endpoint was overall response rate. I'm not going to the details of this demographic, but overall majority of the pediatric population in the range of 94%, and median time to pembrolizumab exposure was 11 months. So the primary endpoint was the PET negativity rate at the end of consolidation, and it found that about 66% of the patients were PET negative at the end of this consolidation, and predominantly for a bulky disease patient, the PET negativity rate is a bit lower. Regarding the toxicity, no new safety concerns obtained. The rate of immune-mediated toxicities, which are predominantly pembrolizumab induced, predominantly occur in the grade 1 and grade 2 in the form of thyroid abnormalities or colitis. The discontinuation rate of this experimental regimen is quite low. So very encouraging data, and after 7 months of additional follow-up, almost 66% of the patients maintained this high risk with slow early response PET negativity rate, and ultimately they actually were spared of radiotherapy, which is very essential for reduction of the long-term toxicity. So ultimate conclusion from the investigators was that addition of pembro to COPDAC28 consolidation may augment the treatment responses in children and adolescent young adult patients with high-risk classic Hodgkin lymphoma and slow early response to initial chemotherapy. Next two trials are almost similar trials, phase 1, phase 2 trials of bispecific antibodies in relapse refractory large B cell in the form of diffuse large B cell or primary mediastinal B cell lymphomas or high-grade B cell lymphomas. So these are glofitamab and epcoritamab, almost similar design drugs, newer drugs. So these are early phase clinical trials. Data is very encouraging, and epcoritamab is already approved in the 3rd or 4th line setting in this disease. So this data is already published, and glofitamab phase 2 data, and this year ASCO and extended follow-up has been presented. So glofitamab is basically a bispecific antibody targeted against CD20 and CD3. It causes recruitment of CD3 positive cytotoxic T cells to the tumor cells, and thereby causing cytotoxic T cell mediated damage to the CD20 positive lymphoma cells. Course is given as a fixed dose every 3 weekly for 12 cycles, and the primary endpoint of the study was CR rate, induction of the CR rate. So as a bispecific antibody, there is a high chance of induction of the cytokine release syndrome with the infusion of this drug. So to mitigate this, initially 1 dose of obinutuzumab has been given, and followed by weekly doses of step-up doses and intermediate doses, and ultimately the phase 2 dose, which is the median tolerated dose or recommended phase 2 dose, which has been found is glofitamab IV 30 mg, given every 3 weekly for total 12 cycles. So patients with DLBCL NOS, high-grade B-cell lymphoma, transformed follicular lymphomas, primary mediastinal B-cell lymphomas, post 2 line of therapy, including anti-CD20 and anthracyclines have been included with the primary endpoint of CR. So regarding the response rate, about 40% patient achieved CR with glofitamab, and with the overall response rate of 52%. And patients who achieved an early response after the cycle 3 of glofitamab, this drug, having a better PFS and OS, and the same thing is true of patients with a maintained CR at the end of therapy on post 12 cycle of glofitamab, they have a better PFS and OS. Predominant toxicities are some form of myelosuppression and neuropathy, although CRS or cytokine release syndrome predominantly happen in grade 1, grade 2. Grade 3, 4 CRS happened only in 4% patient, and grade 3 neurotoxicity only in 3% of the patient. So the conclusion was that most patients in CR at the end of treatment remain in remission, and almost 70% of the patients at the end of 1 year who having a CR maintained CR after 7 months of additional follow-up. So investigator concluded that these data support the potential for favorable long-term outcomes with a flex duration glofitamab for relapse refractory large B-cell lymphomas. Now, epcoritamab also almost a similar design drug. It's also a bispecific antibody targeted against CD20 and CD3. The epcor-NHL1, the data is previously published, and based on this data, this epcoritamab already got FDA approval for the treatment of adult patients with relapse refractory DLBCL NOS, including DLBCL arising from the indolent NHL and high-grade B-cell lymphomas, after more than 2 previous line of therapy, including 1 anti-CD20 antibody and including anthracyclines. So now in this EPCOR-1 trial, in EPCOR-1 NHL-1 trial, this actually included not only anti-CD20 antibody therapy and anthracyclines, but also included previous CAR T cell based therapy for this phase 1, phase 2 dose expansion cohort. Initial data published within 11 months of follow-up, and this extended follow-up has been presented this year ASCO with a 20 months of follow-up. Again, similarly, to mitigate the cytokine release syndrome, initially on priming dose and then step-up dose has been given with a corticosteroid prophylaxis of this bispecific antibody, and followed by the recommended phase 2 dose, which has been found as a 48 milligrams subcutaneously every weekly. So until progressive disease or acceptable toxicity. So initially weekly doses step up, but later on every 2 weekly or 4 weekly cycles after the cycle 10. So again, similar patients have been included, just like the previous glofitamab data, and primary endpoint was overall response rate. So median age was 65 with a good performance score. Patients enrolled, almost predominantly DLBCL patient enrolled, and 1/5 of the patients have been exposed to previous transplant, and almost 40% of the patients exposed to previous CAR T cell therapy. So regarding the side effect profile, yeah, so regarding the primary endpoint, which is the efficacy endpoint, the overall response rate was almost 60% with a CR rate of roughly about 40% and rest of the 22% patient having a partial response. Again, predominant side effect was neutropenia and CRS. And again, just like glofitamab for this epcoritamab drug also, predominantly grade 1, grade 2 CRS happened and grade 3 CRS only in 3 to 4% of the patient. And predominantly for a mitigation of the CRS, corticosteroid prophylaxis has been used, and tocilizumab has been used as a therapeutic purpose for any grade 2, 3 CRS of the drug. So overall response rate was 61% for DLBCL and 63% for large B-cell lymphomas with a 40% CR rate in both the groups, which was quite encouraging. So ultimately, we'll have an ongoing phase 3 data of this drug in post multiple line of failure in a DLBCL cases. Now, this is again a very important update from mantle cell lymphoma, which is the BRUIN2 data. So as we all know that after the introduction of the covalent BTK inhibitors in the form of ibrutinib, zanubrutinib, and acalabrutinib, the therapeutic landscape of mantle cell lymphoma has been completely changed. But the problem is there is a lot of pharmacological fallacies for these covalent BTK inhibitors. Number one, they have a short half-life, and number two, their oral bioavailability is not very good. So that's why there is an suboptimal exposure to the BTK target, and there is a suboptimal coverage of the BTK target by this drug because these are all oral drugs. And these ultimately responsible for development of the acquired resistance and progression of the disease when you treat mantle cell lymphoma with covalent BTK inhibitors. So pitobrutinib is basically a non-covalent BTK inhibitor. It is a highly selective and non-covalent next generation drug. And it already got approval based on this phase 1, phase 2 data for patients, for adult patients with relapsed refractory mantle cell lymphoma after more than 2 previous line of systemic therapy, including 1 covalent BTK inhibitor. So this is again a 2-year follow-up data of this BRUIN data, which has already been presented previously. So again, a phase 1, phase 2 dose expansion cohort, and recommended phase 2 dose found to be a 200 mg per day oral dose. And the primary and secondary endpoints are in line with the phase 1, phase 2 trial. Median age 70 years with almost 1/5 of the patients were non-classic histology of mantle cell lymphoma, and predominantly low and intermediate risk patients of as per the MIPI score has been enrolled. So median prior line of therapy was 3, with almost all patients exposed to prior BTK inhibitor, and a significant proportion of the patients exposed to anti-CD20 antibody as well as chemotherapy. Regarding the primary endpoint, the overall response rate in the prior covalent BTK exposed patients were around 56% with 17% CR. And quite encouraging is patients without the covalent BTK inhibitor exposure. So covalent BTK inhibitor naive patients, the CR rate and overall response rate were much higher. Overall response rate 85%, as well as the CR rate was 42%. Median duration of response almost 17 months in prior BTK exposed patients. So if we look, although the number is very small for non-BTK exposed patients, all the actual number is 14 patients, but if we look carefully that up to 18 months duration of response, PFS, very encouraging data for this subgroup. So I'm not going into the details, but overall classic histology is having a better response in comparison to blastoid and pleomorphic histologies. And regarding the Ki67 also with a high Ki67 having a long duration of response, although PFS is higher with a low Ki67. Regarding the toxicity, predominantly significant amount of fatigue, diarrhea, and bruising and skin rashes happened. But again, these are predominantly grade 1 and grade 2. So in conclusion, overall response rate with this drug was almost 56% and 85% in patients who received prior covalent BTK inhibitor versus BTK inhibitor naive patients. Safety data was consistent with the previous analysis. So there is an ongoing phase 3 trial in the form of BRUIN MCL 321, which compared this pitobrutinib non-covalent inhibitor, BTK inhibitor versus physician choice covalent BTK inhibitor in pretreated mantle cell lymphomas. So next is a phase 2 data for peripheral T-cell lymphoma, bolidositinib. It's a JAK1 selective inhibitor. We all know that this is a very bad disease, peripheral T-cell lymphoma, and relapse refractory disease is very common. And once they relapse after the initial therapy, it's very difficult to manage. With second, third line chemotherapy, the response rate are really low. Poor prognosis, 5-year survival is less than 30%. And so bolidositinib is basically an oral drug, highly selective JAK1 inhibitor with a favorable pharmacokinetics. So again, a phase 1, phase 2 data, and the recommended phase 2 dose for this particular drug has been found as 150 mg daily. Drug has been given until progressive disease or intolerance with a primary endpoint of overall response rate as per ISC. Median patients included almost 112 with a median age of 58, predominantly males and Caucasians. And almost all patients received prior chemotherapy, and almost 50% patients received prior HDAC inhibitors. Regarding the histology, predominantly PTCL NOS included, although all different histologies of PTCL like angioimmunoblastic type or ALCL or NKT-cell all included. So the primary endpoint was overall response rate. It occurred in 44% of the patients with a 24% CR rate. Tumor reduction happened in almost all histologies, although some histologies are absolute number is very low, like for NKT cell lymphomas or for PTCL uncertain. So this comparison between histologies is not very much means robust actually from this data. So duration of therapy is 1.6 months. Predominant toxicities, again, myelosuppression and some form of non-hematologic toxicity in the form of hepatic enzyme elevation and triglyceridemia happened. So in conclusion, median duration of response not reached with a 6.3 months follow-up. Longest duration of response 16.8 months and with an acceptable safety profile. So investigator concluded that this particular drug could be considered as a treatment option for adult patients to relapse refractory PTCL. Now, for the next part of my presentation, I'm going to discuss few important studies regarding the multiple myeloma. First two studies are predominantly phase 1, phase 2 study of again bispecific antibodies, and next 2 trials will be regarding CAR T-cell. So teclistamab is basically again a bispecific antibody directed against B cell maturation antigen, which stands for BCMA as well as CD3. It again causes recruitment of cytotoxic T cell to the plasma cells and thereby causing damage of plasma cells or myeloma cells by cytotoxic T cell mediated action. So it's already approved for a multiple myeloma, more than 4 lines of therapy post triple refractory disease. We exposed already to proteasome inhibitors, immunomodulatory drugs, and anti-CD38 antibodies. So this phase 1, phase 2 pivotal data already been presented, and current analysis is just a follow-up of this step 1 trial. So again, as a bispecific antibody, high chance of CRS. To mitigate that, there is a priming dose and step-up dose, and ultimately the phase 2 recommended dose found to be 1.5 milligram per kg subcutaneously. And once patient having a response, there is an option to switch to more longer interval between the cycles, either 2 weekly or 4 weekly dosing. But this is only for the patients after having a response. Primary endpoint was overall response rate. Median age was 64, predominantly ISS stage 1 and 2 patients included. Again, Caucasian males are more, and about 1/5 of the patient having extramedullary disease. Prior bone marrow transplantation done in almost 80% of the population, and almost 100% are triple drug exposed. Almost 90% are anti-CD38 antibody exposed. So even after more than equal to 3 lines of therapy, including the triple drug therapy, the response rate, if you look carefully, the primary endpoint, the response rate, including stringent CR and CR, the total response is almost 46%, which is quite encouraging, with a median duration of response of almost 21 months. So patients with more than equal to CR, the median PFS is 27 months, OS not reached. At day 100, the MRD negativity rate was 81%. Predominant toxicity is myelosuppression as well as the CRS and neurotoxicity, and sepsis, neutropenia related sepsis. But what is very encouraging that with increasing duration of therapy, the actually new onset grade 3-4 infections decreases. And one of the reason maybe that after the achievement of good response, this drug was allowed to be given not weekly schedule but more longer schedule, like 2 weekly or 4 weekly intervals, which has a potential to reduce the sepsis and neutropenia related infections. So in conclusion, with the median follow-up of 2 years, very encouraging data in relapsed refractory triple drug refractory multiple myeloma. Overall response rate 63%, more than 80% patient achieved undetectable MRD at day 100, and new grade 3 infections were decreased over time. So again, a phase 1-2 data. This is basically a pooled analysis from different phase 1, phase 2, 4 different phase 1, phase 2 magnetis studies included in relapsed refractory multiple myeloma. And this is post B cell directed therapy in the form of ADC or in the form of CAR T-cell therapy. So elranatamab is again a bispecific antibody directed against B-cell maturation antigen and CD3. There was a ongoing phase 3 data in single agent elranatamab in BCMA naive patients, but current pooled analysis is basically BCMA exposed patients. Either patients have been included with all 3 class of drug which are commonly used in multiple myeloma, as well as one BCMA directed therapy, either in the form of CAR T-cell therapy or ADC, antibody drug conjugate. So 87 patients enrolled from the Magentis MM1, 2, 3, and 9 study, predominantly phase 1, phase 2 study. The recommended phase 2 dose found to be 76 milligrams subcutaneously every weekly, and within efficacy endpoints as per the International Myeloma Working Group criteria. Again, predominantly Caucasian males have been enrolled as per revised ISS. The stage 1 and stage 2 patients are more than stage 3, and with a high risk cytogeneity is about 1/4 of the population, about 24th of the population, and extramedullary disease about 54% of the patients. So regarding prior treatments, almost 67% of the patients exposed to prior antibody drug conjugate as a BCMA directed therapy, and 40% of the patients exposed to prior CAR T-cell therapy. Almost 80% patients were post-transplant. Regarding the efficacy endpoints, overall response rate was 46% with a stringent CR plus CR rate including in the range of 18%. Median duration of response about 17 months. Predominant toxicity are hematological with a significant grade 3/4 hematological toxicities. Other predominant toxicities are in the form of CRS, cytokine release syndrome, but it's predominantly happened in grade 1, grade 2, and grade 3/4 CRS is only in 2% of the population. And few important increase infections, so sepsis incidents also happened, but again, grade 3/4 sepsis rate is quite low. So more focused discussion regarding CRS and neurotoxicity. We can stand for immune effector cell mediated neurotoxicity. So again, as we have discussed, the predominant CRS in the low grade, high grade the CRS are lower. And regarding the neurotoxicity, few high grade neurotoxicity happened, but although management with steroids, high dose corticosteroids or tocilizumab required almost in 1/5 of the population. So in conclusion, overall median PFS was 5.5 months. Median PFS after CAR T-cell therapy was 10 months, and after ADC exposure was almost 4 months. So again, very encouraging data. Next 2 trials, one is phase 1, phase 2 data of CAR-T-1, that is one CAR T-cell therapy, ciltacabtagene autoleucel, in heavily pretreated relapsed refractory multiple myeloma. And the next trial is CAR-T-4, which is a phase 3 data. So this drug is already got approved after more than equal to 4 line of therapy as a CAR T-cell therapy in relapsed refractory multiple myeloma. So it's basically comprising of 2 BCMA targeting single domain as well as 1 post-stimulatory domain. Initial phase 1, phase 2 of CAR-T-1 study has presented, and that showed that 27 months PFS rate was almost 54%. Current analysis is a more longer follow-up. So I'm not going to the detail. The standard protocol for CAR T-cell therapy, the screening, enrollment, leukapheresis, and preparation and infusion has been followed. Patients enrolled with relapsed refractory multiple myeloma with a measurable disease and more than equal to prior line of therapy, including agents in the form of proteasome inhibitors, immune modulatory drugs, and anti-CD38 antibodies. Primary and secondary endpoints are in the line of phase 1, phase 2 dose expansion trials. So with this longer follow-up, median PFS has been found as almost near about 3 years, and the 3-year OS found about 62% with no new safety signals. So this is a phase 3 trial. This is also has a practice-changing potential. So from the CAR-T-1 just presented previously, this data, we can see that the median PFS in a very heavily pretreated, more than 4 line of therapy, multiple myeloma, the median PFS achieved with this CAR T-cell therapy is almost 3 years. Now, this phase 3 trial is basically for a lenalidomide refractory relapsed refractory multiple myeloma. Previously, 1 to 3 line of therapies has been allowed, but patient has to be lenalidomide refractory, and with a head-on comparison between standard physician choice chemotherapy, which is either daratumumab based or pomalidomide bortezomib based, versus CAR T-cell therapy. So patients with lenalidomide refractory multiple myeloma often have less than 1 year median PFS in real-world studies, and these are really difficult to manage. Now, CAR T-cell therapy, ciltacabtagene autoleucel, this targeting the B-cell maturation antigen that got FDA approval already as per the CAR-T-1 study in relapsed refractory multiple myeloma after more than equal to 4 lines of previous therapy, and that has shown a median PFS of almost 3 years, just as per the previous data. So this again founding the background of this CARTITUDE 4 phase 3 data, which is a 1:1 head-on comparison, phase 3 fashion comparison between physician choice chemotherapy, which is either bortezomib, pomalidomide, dexa, or daratumumab, pomalidomide, dexa versus CAR T-cell therapy in this poor population subgroup of multiple myeloma. So 1:1 randomization, 1 to 3 prior line of therapy is allowed, including 1 proteasome inhibitor and 1 immunomodulated drugs. Patient has to be lenalidomide refractory and no prior CAR T-cell therapy or BCMA-directed therapy was allowed. So primary
Last
endpoint.
2 minutes.
Yes, sir. Yes, sir. So primary endpoint was PFS, and again, 54% of the patients were actually 59% of the patients were actually high risk. The primary endpoint, if we look carefully, the 12 months PFS was significantly higher, 76% versus 49%, favoring the CAR T-cell group. Almost all pre-decided subgroups favoring the CAR T-cell group. And overall response rate much higher in the CAR T-cell group in the range of 84% with a stringent CR of 58%, which is quite encouraging. The PAR protocol analysis also suggestive of very encouraging data with the CAR T-cell group. So side effect profile again predominantly neutropenia and infections, and as well as cytokine release syndrome and neurotoxicity, although these are predominantly low grade. So conclusions are that PFS benefit observed across all subgroups, and the median PFS is still not reached with this CAR T-cell therapy versus almost 12 months with the standard of care therapy. So investigator concluded that this CAR T-cell therapy has a potential to be the new standard of care for patients with lenalidomide refractory, newly diagnosed lenalidomide refractory multiple myeloma. Now this is the last study I'm going to present. So basically, all we know that the standard of care for management of anemia in a transfusion-dependent low-risk MDS is erythropoietin, but there are a lot of pharmacological disadvantages, including the low duration of response and sometimes suboptimal response. So luspatercept has a very encouraging drug. It's basically a promoter of the late phase erythroid maturation. And we have data from Medalist phase 3 trial and PACE MDS phase 2 data regarding the encouraging activity of luspatercept to achieve RBC transfusion independence in low risk transfusion dependent multiple myeloma. So this phase 3 trial is basically a phase COMMANDS trial, basically a 1:1 randomization and a phase 3 comparison between erythropoietin alpha versus luspatercept in low, intermediate and very low risk MDS. We are with the primary endpoint of RBC transfusion independence at 12 weeks with a concurrent mean hemoglobin increase of more than equal to 1.5 gram per DL. So I'm not going to the details. The primary endpoint was significantly better in the luspatercept arm with a 58% achieved the primary endpoint versus 31%, almost doubled for luspatercept arm. And the benefit was melted all the pre-decided subgroups depending on the baseline endogenous EPO level, depending on the presence or absence of the RS status and baseline RBC transfusion burden. So regarding the toxicity, few hematological and non-hematologic toxicities are predominantly in the range of fatigue, thromboembolic events, and hypertension. So again, investigators concluded that upfront luspatercept is a paradigm changing for treatment of anemia associated with transfusion-dependent low-risk MDS patients. Thanks. I believe that's my last slide.
Thank you, Tamojit, for that wonderful update. I think with a lot of these therapeutics coming into our clinical practice, I think myeloma patients as well as lymphoma patients will live longer, especially they will have a better quality of life, less toxicity, and maybe their quality of life can be considered as equivalent to as other normal people, age-matched people. Thank you for this wonderful update.
There are questions in this thing.
Questions in the chat box, sir? Just yeah, so do we replace nivolumab for brentuximab for first line advanced Hodgkin lymphoma with 1 year of follow-up data? So answer is absolutely no. Data is very encouraging, but till now, if we look, if you remember that the category 1 recommendation for brentuximab plus AVD came only after the publication of 6-year overall survival for this experimental regimen. So I believe for Nivo plus AVD regimen also, we should at least wait for 5-year overall survival before taking any final conclusion. Next question is, should we really worried about long-term irreversible toxicity of Nivo in a curable disease like Hodgkin lymphoma? So again, it's difficult to answer because Nivo plus ABD, we don't have till now the long-term toxicity data. We have data from other phase 2 trial regarding the first line Nivo plus ABD. But keeping in mind that for this advanced stage disease, for long, probably I believe after the introduction of ABBD regimen, long it is almost last 1.5 decade that no other regimen has shown OS benefit except the brentuximab ABD data. The BCOP regimen and all other more toxic regimen for pediatric population like OBDAC 28, these all have shown 5-year or 10-year EFS benefit or PFS benefit, not shown any OS benefit. So just 2 years back, brentuximab plus ABD has shown OS benefit, and now we are having a very encouraging EFS or PFS data even from brentuximab when we use Nivo. And keeping in mind that Nivo, there is a biologic scientific rationale of using it in classic Hodgkin lymphoma, because the PD-1 ligand genetic modification is actually central to the pathogenesis. If we look at the pathogenesis of the advanced classic Hodgkin lymphoma, the different number of genetic alteration of PD-1 ligand, which is situated in 9p24.1 locus, the different form of amplification or copy number gain or translocations are actually numbers are higher for advanced Hodgkin lymphoma, and with a high number of the genetic alteration, if we use conventional chemo regimen, the response rate is lower. So probably that is my mistake till now, that with a scientific rationale for an advanced classic Hodgkin lymphoma with a high degree of PD-1 ligand genetic alteration, probably Nivo will score better in terms of efficacy endpoint, but in terms of toxicity endpoints, it is probably we should wait at least 5 or 6 year data from this work study.
Okay, thank you, Tamojit, for that wonderful talk. Now, the next topic is on CML and CLL. I think Dr. Rajiv will chair the session.
Thank you, Lokesh. The next half an hour, our good friend Mahesh will be highlighting the CML, CLL, and bone marrow transplant updates. He is an eminent hematologist from Sparsh Hospital, good friend of us. He looks young, but he is having more than a decade experience in the field of hematology. Mahesh, over to you. Thank you.
Thank you, Rajiv. Is everybody able to see my slides?
Yes, Mahesh, you can.
Okay, so I will start. So basically, I think a lot of medical oncologists have a lot of these CML cases as well as the chronic lymphoid leukemia cases. This CML update was recently published in Nature just 2-3 months ago, and the whole summary is about that particular update. So everybody knows that it's basically a myeloproliferative neoplasm which occurs as a result of the Philadelphia chromosome, which is basically resulting in a BCR-ABL tyrosine kinase activity and finally leading on to cell proliferation and increased differentiation rather than cell arrest. So could you identify these 3 people who are there? These are very important scientists in the field of targeted therapy. To start with, these 2 people are Noel and Hungerford, who identified for the first time the Philadelphia chromosome. This lady identified the BCR-ABL tyrosine kinase activity in the Philadelphia chromosome. Do you remember what's her name? This is J.K. Rowling. And finally, because you need to have the targeted therapy era started with this particular man who finally used imatinib in the treatment of chronic myeloid leukemia. His name is Brian Dutker. With this short introduction, so what is new while you are evaluating the case of a chronic myeloid leukemia? So basically, I think very often we tend to miss doing karyotyping because we are not getting enough samples from the bone marrow. But at least we can do a peripheral blood karyotyping, which is important because sometimes we look at isochromosome 17, sometimes we look at a deletion 17q and 3q rearrangements. These particular chromosomal abnormalities are important because these particular patients having abnormalities have an accelerated phase as well as they can easily progress to the blast crisis. And hence, for these patients, probably you may use a second generation tyrosine kinase inhibitors ahead of imatinib. FISH is definitely important for all patients with chronic myeloid leukemia, especially if your PCR comes negative. PCR may come negative if you are looking for unknown transcripts, unknown BCR-ABL transcripts, if the PCR is not programmed to detect such a transcript. Hence, FISH in such a cases, it has got less false negatives, and hence FISH for BCR-ABL is definitely necessary, especially if your PCR comes negative. Recently, me and my close friend Lokesh had one patient wherein PCR was negative, but finally FISH for BCR-ABL came positive. That was basically because of the unknown BCR-ABL transcript, which was not picked up on the PCR. And that particular patient responded very well to tyrosine kinase inhibitors. Comprehensive leukemia panel, not everybody does it, but probably if you have done it for some person, some reasons, or if the patient has asked to do a comprehensive leukemia panel, and in such a case, if you are detecting an ASXL1 mutation, this particular subset of patients may progress very badly, and they may progress to accelerated as well as blast crisis. And this particular subset of patients again have to be treated with second and third generation tyrosine kinase inhibitors rather than imatinib. So very often we feel that thrombocytosis cannot be CML, especially when the total count is bang normal. I myself had an experience of at least 2 patients wherein they just presented with high platelet count without having a high white cell count. Even those patients need to be tested for CML, and you need to do FISH as well as PCR for BCR-ABL in this subset of patients, because sometimes they can just, especially in pregnancy, they can just present with thrombocytosis. Very often people tend to ask questions, and even the red ones, the patients come and ask, why don't you do a tyrosine kinase mutation testing upfront? But most often it is not necessary, because the recent German CML4 trial showed that the percentage of detecting a BCR-ABL tyrosine kinase mutation in early CML is as low as less than 5%. So you don't want to do a tyrosine kinase mutation testing while you start the therapy for chronic myeloid leukemia. So now everybody might be wondering, there you have got so many tyrosine kinase inhibitors. You have dasatinib, bosutinib, nilotinib, ponatinib, and recently we have asciminib. So is the era of imatinib gone? Does the imatinib doesn't have any role to play in the future, considering that you are aiming for a treatment-free remission? But I feel that old is still gold, because overall survival is still good with imatinib, and toxicity profile when compared to dasatinib or other medications is much better with the imatinib. Cost of TKA, imatinib is much cheaper, but with all these generics coming into existence in India, the cost of TKAs is much cheaper than what we see in US and other countries. More or less, the dasatinib is as equivalent to imatinib when it comes to cost. What is more important while you decide about treatment, starting a treatment with a patient who is having CML, is the age of the patient and comorbidities of the patient. As you can see, if the patient is frail elderly, probably the best drug to use in those subset of patient is either a very low dose dasatinib at 20 milligram, or maybe imatinib 400 milligrams per day. And of course, if the patient is having cardiovascular diseases, you tend to use dasatinib and bosutinib upfront rather than nilotinib, because nilotinib has got a lot of these cardiovascular events, and especially when you are using it for a long time, that there's a 23% chance that the patient could land up with the ischemic heart disease, CVA, or other vascular events. And if the patient is having chronic lung disease, definitely you are not supposed to use dasatinib, especially with the pleural effusion and pulmonary hypertension, which can happen with dasatinib, though there is a role for using nilotinib and bosutinib. And similarly, in a patient who is having an hepatic and a gastrointestinal disorder, especially if there is a risk of having an enterocolitis, probably there you should not be using bosutinib, because bosutinib has got a lot of hepatic and gastrointestinal toxicity. You require a close monitoring. In those subset of patients, probably a better drug would be nilotinib or a dasatinib. And of course, the CML risk strategy is very important upfront. All your patients, you have to do SOCAL scoring upfront, because if your patient is having a high SOCAL score, there is a high tendency that they may progress to accelerated or a blast crisis. For those subset of patients wherein the SOCAL score is high, probably you may have to use second generation TKA inhibitors rather than imatinib. So it is important to take into consideration the age of the patient, the comorbidities of the patient, and to see whether you are aiming for overall survival or just a treatment-free remission. Suppose if you are aiming for a treatment-free remission, there the better drugs would be second-generation TKIs, because second-generation TKIs, as you are aware, can cause deeper molecular remission, and they also can cause earlier molecular remission. Unlike imatinib, which may take a little bit longer time. But if you are intending not to achieve a treatment-free remission, you don't want to stop this particular medication in your patient, then it doesn't matter which TKI you're using. You just take into consideration the age and the comorbidities. And in those subset of patients, if you just want to improve survival, probably imatinib would be the best drug. I think everybody is aware of all these landmark trials, the IRIS, the Decision, NEST, and before, which sees mainly the 4 tyrosine kinase inhibitors which are readily available in the market. You can see that the overall survival is not at all different in all the 4 tyrosine kinase inhibitors, and even the event-free survival in the long term is almost equivalent. What matters is the deeper molecular remissions and the complete cytogenetic response, which is much robust and happens earlier with dasatinib and nilotinib. Now, everybody keeps on asking the question, and we are also hellbound to achieve these milestones. We need to follow the ELN guidelines. We need to follow the NCCN guidelines very strictly. We need to look into whether your patient is in yellow zone, red zone, green zone, whether it is very important to follow these milestones. The recent Nature publication says that it may not be required. Very often, it may not be required to achieve all these milestones, especially the 6-month time point is more important than the 3-month time point. So at 3 months, you may not do BCR-ABL quantitative PCR, which we have been doing often repetitively. Lack of EMR at 6 months, that is early molecular response at 6 months, is very important when compared to the molecular response at 3 months. Various people, especially the Shai et al. Group and Bidiken et al. Group, showed that 10-year CML survival is equal whether you are achieving a BCR-ABL of 0.1 to 1% or achieving a BCR-ABL transcript of 1 to 10%. The 10-year CML specific survival is almost equivalent whether your BCR-ABL is in this group or is in this group. So whether you want to follow BCR-ABL transcript, whether you want to achieve the 0.01, 0.5 target, and whether you want to change the medication is questionable. So I would be happy in a long run, if you don't want to achieve a treatment-free remission, if you are able to maintain a BCR-ABL of less than 1%, that should be fine. Only thing is that if your patient's BCR-ABL is above 0.1%, you monitor them more frequently, maybe once in 3 months. If the patient's BCR-ABL is less than 0.1%, then you don't have to frequently monitor the BCR-ABL. Probably you may have to monitor BCR-ABL 6 months. That means that BCR-ABL transcript levels of less than 1% is okay if I am not going for the stoppage of treatment in the long run. So now, how about achieving the treatment-free remission? So very often you might have seen young females who want to get married. Very often you see a young male who wants to get married and want to stop the treatment. Who are the subset of patients wherein you decide that you can stop the treatment? These are the criteria. Somebody with a low SOCAL score, BCR-ABL has to be a standard one like E31A2 and E14A2. CML always in a chronic stage, never in accelerated or response with a first TKI. Duration of response, duration of TKI, they should have continued for at least 6 to 8 years. The molecular response should be more than 4, that is the deep molecular remission. Duration of molecular response should be at least 3. That means that you have started the medication. If your patient has achieved a deep molecular remission for at least 5 years, then you can intend to stop the medication if the patient is in low SOCAL score. As you can see here, if the patient has all these criteria fitting in, if the patient has got all these criteria fitting in, you can stop dasatinib or whatever medication you have started in at least 50% of the patient, and you have seen that in a long-term data, none of these patients had relapsed. So if a young patient, young female or a young male comes and asks you whether I can stop the medication, you can go through this. If all these are achieved and if the patient is on second generation TKI inhibitors, probably you can stop medications, and most of the patients are happy to stop the medications because they want to get married, they want to conceive and all that. So what do you want to do next when there is, you often see that patients are failing the TKI therapy. So you basically want to look what are the reasons for the failure. Sometimes it could be the toxicity, sometimes it could be the tolerance problems, sometimes it could be the compliance problem. Initially, even our data says that historically the incidence of failure were as high as 50%, but there are certain reasons why TKA failures were much higher in the historic data when compared to the present data, because you were chasing the BCR-ABL transcript levels very madly, and we were changing the drug often for the minor complications or the minor side effects. And if you don't do that, the TKI failure rates are less than 20%, and most of the patients will be able to continue TKI therapies. So very often you have seen your patients developing side effects with imatinib 400 milligram. Very often you have seen your patients who are on dasatinib having frequent pleural effusions, some amount of pulmonary toxicity, pulmonary hypertension, developing side effects when they are on 100 milligram. And very often you have seen neurological side effects, vascular events, skin rash. All this can happen with the full dosage of nilotinib. And even with bosutinib, you have seen gastrointestinal side effects. Are there any ways by which you can reduce the dose? Again, this recent article in the Nature says that if you have achieved an optimal biological dose, which should be sufficient. There is something which is different from the chemotherapy, wherein you are targeting the maximal tolerated dose, but when it comes to CML, what you are targeting is a optimal biological dose. Suppose if the patient has got a good molecular response, that is, if the transcript levels are less than 0.1%, you can safely reduce the dasatinib dose from 100 milligram to 50 milligram. You can safely reduce the dose of bosutinib. And similarly, same thing holds good for imatinib as well as dasatinib. This is a recent article which was published from US, and they compared the 50 milligram dasatinib versus 100 milligram dasatinib. What you can see is that the complete cytogenetic response, the major molecular response, MR4 and MR5 were all better in the 50 milligram arm when compared to the 100 milligram arm. So that now you can safely say that I don't want to use 100 milligram dasatinib in your patient. You want to use 50 milligram dasatinib. Of course, when you are starting with the low dose of dasatinib, probably you may have to monitor BCR-ABL transcripts more frequently. And with this change in the dose of dasatinib, the toxicity profile has much improved. There are less pleural effusions, there are less pulmonary hypertension, less side effects, and less oral fluid overload. And all these toxicities come low when you are giving a low dose of dasatinib when compared to the high dose of dasatinib. Very often you can see this red, yellow, and green charts. The TKI mutations can happen at all regions of the TKI gene. And what do you define as a resistance? If the BCR-ABL transcripts are more than 1%, after 1 year of frontline TKI therapy, you call them that probably this particular patient might be resistant to the upfront TKI, especially if you have started on imatinib. You have always other 5 medications to choose from, that is dasatinib, nilotinib, bosutinib, ponatinib, and asciminib. What you need to take into consideration is again the age of the patient, the toxicity profile of the patient, the comorbidities of the patient. As you can see here, the complete hematological response, the major molecular response, is equal with all these medications. And even the overall survival rates are almost similar. They are all excellent, in excess of 90%. The long-term survival data is already there for dasatinib and nilotinib. Hence, when you're choosing second and third generation TKIs, what is more important is to see what is the mutation, because T315 mutation, nothing works except for the ponatinib and asciminib, and whether the patient is having any comorbidities. For lung conditions, don't use dasatinib. For vascular conditions, don't use nilotinib. For intestinal conditions, don't use bosutinib. And ponatinib, you got to be careful with vascular events as well as for the intestinal events. So the third generation tyrosine kinase inhibitors, we have got a good experience with using ponatinib. I myself had not had any personal experience with asciminib, but if you are using asciminib in your practice, the usual dose is around 40 milligrams BID. What I do with ponatinib is If your patient is having T315I mutation, you start high at 45 milligram per day. And as and when the BCR-ABL transcript levels come below 1%, you can reduce the dose of ponatinib to 15 milligram. And if you are not having a patient with T315I mutation, you can start at a lower dose, that is 30 milligram instead of 45 milligram. And as soon as you achieve a BCR-ABL transcript levels of less than 1%, you can immediately come down on the dose of the medicine to 15 milligrams. So these are various landmark studies in the era of ponatinib and asciminib. All show that they are very good drugs for T315I mutation, very good drugs for non-T315I mutations, good overall survival data, progression-free survival. I will not go into the details. This PACE trial and OPTIC trial is for ponatinib, which shows good amount of major cytogenetic response, complete cytogenetic response, major molecular response, all are good with PACE trial as well as in OPTIC trial. OPTIC trial is basically a de-escalation trial wherein they reduce the dose of ponatinib from 45 milligram to 15 milligram as soon as the patient achieved BCR-ABL transcript levels of less than 1%. And again, managing toxicities in 2023. So there you can broadly categorize into common side effects and prohibitive toxicities. You need to look at the common toxicities. Very often what we oncologists and hematologists tend to do is, suppose if a patient develops any side effect, you immediately change the medicine from imatinib to dasatinib, dasatinib to nilotinib. That should not be done. If the patient is having common side effects, just reduce the dose of the medication. Say, for example, if on imatinib, if he is developing these rashes, these minor side effects, and if you have achieved a durable molecular remission, why you want to unnecessarily change it to other medications? Just reduce the medication to 100 to 200 milligrams. Similarly, with nilotinib, the lowest dose which can be given is 200 milligrams per day. And similarly, with dasatinib, you can give a lowest dose of 20 to 50 milligrams per day. So that is what you want to do. Whenever there is a side effect which is happening, always try to reduce the dose rather than changing the medication from one medication to other medication. You just reduce the dose, see if the patient tolerates it, see if the BCR-ABL transcript levels are good, and then if the BCR transcript levels are increasing, then you can move to the second generation medicines. So, however, there are certain side effects wherein you have to immediately change the medicine. Suppose if your patient is developing recurrent pleural effusions on dasatinib, you've got to change the medicine. Suppose if your patient is developing pulmonary hypertension on dasatinib, you cannot continue dasatinib. Suppose if the patient develops vascular events, you are not supposed to continue nilotinib and ponatinib. If the patient develops a bad enterocolitis on bosutinib and sometimes with dasatinib, you got to immediately stop the medication. Sometimes I have seen peripheral neuropathy, severe peripheral neuropathy with dasatinib as well as the nilotinib, and dementia with imatinib. So if these side effects develop, you may have to stop the medications immediately. And myocarditis, hepatitis, and nephritis, these are again an indication to consider for the alternative tyrosine kinase inhibitors. So I will conclude the talk on CML here. How much time do I have for the CLL? Rajiv?
5 to 6 minutes.
Okay. So CLL update. So there are a lot of practice changing things which have happened in the CLL treatment. We now term CLL as the cancer that killed chemotherapy. There are reasons to say why CLL is a cancer which killed chemotherapy, and it is one of the most frequent types of leukemias. We know that there are a lot of molecular rearrangements which happen in the pathogenesis of CLL, which we usually tend to target. And finally, the end events which result in refractoriness to chemotherapy is basically the T53 mutations, the Notch mutations. You can target the CLL cell at various levels. You can target at PI3 kinase levels by using IDELA. You can target BTK inhibitors, and recently my friend talked about pirobrutinib. We talk about ibrutinib, acalabrutinib, and zanubrutinib. We can target BCL2. BCL2 is one molecule which is very important. It always tells CLL cells to multiply, and I am going to give you resistance to chemotherapy. But by giving BCL2 inhibitor, what you can actually do is we can take the CLL cells to apoptosis. And if you want to achieve the minimal residual disease in patients with CLL, this is one of the best drugs to use. And we have had some good experience of using venetoclax in 4 or 5 CLL patients. And of course, diagnosis, there is nothing new in the CLL. But what is new is that you don't have to look at all the molecular mutations in CLL. What you need to look at is upfront, you need to look for deletion 17p, you need to look for P53 mutation, you need to look for basically the IGVH, the immunoglobulin variable heavy chain region mutations. You don't have to check for IGVH mutation every relapse, because IGVH mutation is one mutation which is not going to change. That is, the unmutated will not become mutated in the future. That is why once you have checked for IGVH mutation, you don't have to check it always. But only thing which you need to see while you are evaluating a patient with CLL is what has happened to 17p, what has happened to a P53 mutation. These things are important rather than looking into CD38, other molecular mutations. All those are not important while you are making a diagnosis or following up a case of CLL. Right staging and benign staging with these newer targeted therapies, this staging has been not so important, because RI1 and RI4 equally benefit from the targeted therapies, and the response rates has been equally good. The indications of treatment more or less depends on the International Working Group classification, which was published in 2018. There are so many prognostic criteria which have been put forth earlier for evaluating a patient with chronic lymphoid leukemia and understanding how these patients are going to do. But these mutations in the era of targeted therapy is not so important. What is important is just look into what has happened to P53, just look into what has happened to 17p deletion. And again, this mutation specifically, whether you are having an IGVH mutated status or unmutated status, is very important. And what you actually need to do while you are taking a patient for the treatment is to identify whether your patient is fit, less fit, or not fit at all. Suppose if your patient is fit, you can go for a very intensive therapy. Sometimes you can go for a triple therapy with obinutuzumab, acalabrutinib, and venetoclax. You want to achieve the long-term remissions in these patients, and sometimes you also want to ask for the treatment-free remissions. Group 2, you may want to go slow. You want to just give an oral agent. You just want to control the disease. And group 3 is the one wherein there is high comorbidities, there is high fatality rates. There, you may just want to give a palliative therapy. So, new treatment algorithm, which was published recently, just looks at only two things: whether there is a deletion 17p or a P53 mutation, or whether your patient is having a immunoglobulin heavy chain mutated or unmutated status. As you can see in all the subgroups, the drugs have been more or less the same. You are using either ibrutinib, you are either using venetoclax obinutuzumab or acala obinutuzumab. And only in certain subset of patients, young patients, IGVH mutated, and those who are not having 17p deletion, there is a role for using FCR and bendamustine rituximab. So if you want to say whether there is chemoimmunotherapy is over for CLL, I would rightly say so. Chemoimmunotherapy is used only for a limited subset of patients, and most of the patients in chronic lymphocytic leukemia, whether it is in an upfront setting or in a relapse setting, refractory setting, they just receive targeted therapy. Here also, if you are using frontline BTK inhibitor or anti-CD20 monoclonal antibody upfront, probably those patients will receive venetoclax rituximab. And if you have started the patient on venetoclax obinutuzumab therapy, those are the subset of patients, you have to change the therapy into BTK inhibitors. So there are many frontline therapies to choose from. You have Ibru, we have Acala, we have Zanu, we have Piro, we have venetoclax with obinutuzumab and various other triple combinations. And of recently, the BITES therapy, which already Tamojit told about in the same. Similarly, we can use it. However, CAR T cell, unlike lymphomas, has not shown much benefit in the CLL patient. So if you want to ask, are we done with the chemotherapy? Yes, of course, we are done with the chemotherapy. So just going through some of the trials with ibrutinib. Ibrutinib causes a lot of toxicity. I had a bad experience in using ibrutinib for my patients. A lot of patients had led to death. They had various other complications like atrial fibrillation, infections, pneumonitis, bleeding, diarrhea. So if you want to ask me, considering that ibrutinib is half less costlier than acalabrutinib, whether you want to use acalabrutinib, yes, of course, I want to use acalabrutinib, because toxicity sometimes cannot be managed in ibrutinib. So this is a elevate study for a treatment naive patient. The study's design is such that it was equally randomized. All were treatment naive patient. As you can see that most of them were elderly patient or patients with comorbidities with a good performance status. Some had deletion 17p, some did not have it. They were all equally balanced. There were 3 trial arms, Acala with obinutuzumab, Acala with monotherapy, and obinutuzumab with chloramicin. And the overall, the primary endpoints which they saw was progression-free survival with Acala obinutuzumab versus obinutuzumab and chloramicin. You can see here the curves, the Kaplan-Meier curves have flattened. That means even at the age of 65 years, if you are using acalabrutinib with obinutuzumab, patients are living longer, and you can see that their overall lifespan is as equal to the age-matched controls. That is how the targeted therapy has changed the lifespan as well as the quality of life for the CLL patients. It works beautifully both in deletion P, 17p as well as in unmutated IGHV status. So if you have this particular set of patients, Acala is the drug to choose for. And you can see that MRD status is not achieved to a significant extent in patients who are on Acala obinutuzumab. It is just 21%, unlike venetoclax, which may reach up to 84 to 90%. So as you can see that it is a very selective, Acala is very selective BTK inhibitor, unlike ibrutinib, which is a pan BTK inhibitor. That is why toxicity like atrial fibrillation, bleeding, infections, and arthralgia is more with ibrutinib when compared to Acala. This is Elevate RR, that is, which was studied in the relapse refractory setting, wherein Acala was compared with ibrutinib. It showed that both the curves are similar when it comes to progression-free survival, but what matters is the toxicity. You can see that atrial fibrillation, bleeding events, hypertension, everything is much more with ibrutinib when compared to Acala. And similarly, Acala was studied and compared with other important regimen like Adela rituximab and Benda rituximab. Acala was much more superior in all the subgroups. Let it be 17p, let it be IGHV, let it be the overall population considered. It was much more, it showed much more important disease-free survival, progression-free survival when compared to. The dosing is very simple. You want to use 100 milligram twice a day, and you want to just modify the dose. If they are developing any side effects, you may want to start it at a lower dose of 100 milligram once a day, and again directly increase it to twice a day. And most often it has got no interaction with food, but you got to be very concerned about using proton. You cannot use proton pump inhibitors with acalabrutinib. H2 inhibitors, even if you want to use ranitidine, you should give a 3-hour gap when you are giving acalabrutinib. There are some joint concerns like joint pain, diarrhea, which are easily manageable. You got to be careful sometimes when you are using it in renal and hepatic derangements. So venetoclax, as I already said, is a very important molecule. You always have to start low because it causes significant tumor lysis syndrome. We have lost 1 or 2 patients for significant renal failure, tumor lysis syndrome. So you should always ramp up the dose, start at 20 and slowly increase every week up to 400 milligrams. However, if you are giving posaconazole for some other reasons, your dose has to be capped at 100 milligram and not to increase till 400 milligrams. And there are various trials. This is one Murano study. We showed venetoclax rituximab was much superior to bendamustine rituximab arm. You can see that the progression-free survival as well as the 4-year overall survival was much better. And this venetoclax can be combined easily with our newer monoclonal anti-CD20 antibodies like Gazyva and the older ones like rituximab. If you are giving with Gazyva, you want to start it 1 month later. But if you are giving with rituximab, you can start it simultaneously. You can see that the 12-month progression-free survival and 3-month progression-free survival are equally good, and most of the patients live longer with a better quality of life. And what is more important
you have
is that
only
the
2 minutes.
Yeah, over.
Last minute.
Few slides. Yes. MRD status is achieved much better with this venetoclax obinutuzumab combination up to 87%. So if you want to achieve MRD status negativity for your patient, And if you want to give a treatment-free period for your patient, venetoclax, obinutuzumab would be a better combination. So I will skip all these slides and we'll just go to the recent studies which were published in the ASH. This is a GLOW study which compared ibrutinib which was ramped up to 3 cycles. And then ibrutinib was combined with venetoclax. This was compared 1:1 with chlorambucil and obinutuzumab. There were all the population subsets were equally matched in all aspects. You can see that the progression-free survival was significantly better with ibrutinib combined with venetoclax. So it is an era of combination therapy now for probably in CLL patients. It is much better. And even the MRD status was significantly much better. In this Captivate study, again comparing ibrutinib with venetoclax with chlorambucil obinutuzumab, the MRD status was much better. There were at least 80 to 85% achieving MRD negative status in patients who received ibrutinib with venetoclax. This is a standard alpine trial wherein Zanu was compared with ibrutinib, 160 milligram twice daily with ibrutinib 420 milligram once daily. What it showed was almost an equivalent progression-free survival, some differences. What is important, the toxicity profile. You can see that the ibrutinib causes much more cardiac events, much more serious events, much more deaths when compared to zanubrutinib. Probably in coming era, zanubrutinib and pirtobrutinib will replace ibrutinib as well as acalabrutinib. The Bruin study, the picture is not so clear, which compared pirtobrutinib with ibrutinib, and pirtobrutinib in combination with rituximab was compared with venetoclax rituximab. And again, the AO trial, I think this will come into forefront when it comes to treatment-free remission in chronic lymphocytic leukemia. This is a combination of acala, obinutuzumab, and venetoclax. The treatment-free remission period can be achieved by using this combination, and definitely in coming days, this is one trial which is worth looking for, and maybe use it in your patients. And of course, as I said, CAR T-cell therapy, because the disease is there everywhere, it may not be as much feasible when compared to patients with lymphoma. And hence, I would go for targeted therapy rather than CAR T-cell therapy when it comes to chronic lymphocytic leukemia. These are my conclusions. There are a lot of novel targeted therapies to choose. Relapse options include acala, ibrutinib, you have duvelisib and idalizib. This Idala is not a very safe drug because it causes a lot of gastrointestinal and hepatotoxicity with 30% death rates have been noted in some of the trials. Though effective, as I said, PI3 kinase inhibitors has got a lot of toxicity profile. CAR T cells has shown promise, but not to a great extent when it comes to CLL, and stem cell transplant for early relapsing patients, recurrently relapsing patients, young patient is always an option. Thank you.
Thank you, Mahesh. You detailed about both two chronic diseases, and you rightly highlighted they are the people are doing with the targeted therapy and living with the on par with the age-matched control. And you rightly said the era of no chemotherapy or no immunotherapy, only the targeted therapy. So hope you have cleared all the doubts. There is no question in the question bank. And thank you.
I wanted to ask Mahesh, what is your take? Imatinib still at present?
So I think we should still continue to use imatinib because sometimes the toxicity profile, especially in a patients, if you have an elderly patient, lot of comorbidities, again, imatinib is one of the wonderful drug to use for. I myself have an experience of using imatinib close to around 8 years now. I am able to continue imatinib in at least 90% of the patients. None of the patients had any kinase domain mutations. None of the patients had any major toxicity. And again, if you want to give the drug and forget about the patient, imatinib is a drug to choose for. If you want to give the drug and monitor the patient thoroughly, you can choose for second generation tyrosine kinase.
You are rightly mentioned also. Gold is still gold. We accept that. Even in the clinical setting, real world setting, it is still a gold. So as you rightly mentioned, it doesn't require much monitoring also. Thank you, Mahesh. I conclude here. Thank you. Over to Lokesh.
Oh, thank you, Dr. Rajiv and Dr. Mahesh, for an excellent session. Now we'll move on to updates on head and neck cancer. So I'll be chairing the session, and speaker is Dr. Deepak Koppaka, the senior consultant medical oncologist, Kaizen Hematology Oncology Network, Care Hospitals, High Tech City, Hyderabad. So over to you, Deepak. Not audible. You're not audible.
So, sorry, I would like to thank Rajiv sir and Lokesh sir for giving me this opportunity. It's always an honor to present with your mentors. Thank you, sir. So I will be talking about head and neck cancer updates, predominantly from the ASCO that was a month back. So frankly speaking, the major data which is practice changing in head and neck cancer was not really presented. And the only data that was really worthful for our practice comes from the Tata CRSF group regarding oral metronomic therapy, which we are widely using in our practice. Other than that, more of the data that was presented at this ASCO was about the future trends that might evolve in the future trials that might happen in this space. Most of the data that has come up in the nasopharyngeal space is coming from China. We don't see that kind of loads here, but once in a while we see a pool of nasopharyngeal cancer coming up. So I'll be discussing briefly about these studies. Most of the data in nasopharynx comes in the early stage, the metastatic and the advanced stage. Predominantly, the data is about chemoimmunotherapy. The controversy is about induction chemotherapy, the consolidation chemotherapy space in nasopharynx. Now, coming to the rest of the head and neck cancers, data is predominantly about radiosensitizers, induction chemotherapy, immunotherapies, and ways of handling metastatic head and neck cancer patients. So, three predominant studies were presented. One is about induction chemotherapy alone with radiotherapy. So once the patient can be considered for radiotherapy alone, if it has to be preceded with induction chemotherapy, versus the standard of care that was chemotherapy radiotherapy was the first study. The second is if patient received induction chemoradiation, what is the regimen to consolidate it with? Is it gemcitabine versus 5FU based regimens? Considering that neoadjuvant gemcitabine based regimen is now the standard of care. And the last thing is, does immunotherapy have a space in early stage nasopharyngeal carcinoma? So coming to the studies, so the standard of care is induction chemotherapy, chemoradiation, followed by metronomic chemotherapy, which is the current practice. Most of these practice changing data were discussed in ASCO. Now, how would it change? So the first study is again from China, which is induction chemotherapy plus radiotherapy versus concurrent chemoradiation. Here they've given only 2 cycles of gemcitabine and cisplatin, followed by radiotherapy alone. So this is the only phase 3 study where currently is evaluating radiotherapy alone with induction chemotherapy versus chemoradiation. There was no consolidation or induction chemotherapy in the standard arm in the study. Most patients were locally advanced with N2, N3 disease. Some T3, T4, and around 20% patients of this were taken. It's a non-inferiority study of inferiority margin of 10% for the induction chemotherapy arm. So around 125 patients in both arms were randomized. Most patients had T3, T4 disease, and DNA copy load of more than 4,000 was seen in only 25% of the patients approximately. So patients receiving full dose in induction chemotherapy, around 87.9%, 9.9 patients received gemcitabine cisplatin. And remember, there were only 2 cycles of this regimen were given, and around 82% of the patients received full dose of concurrent cisplatin. So here, after 3 months after chemo, 3 months after radiotherapy in both arms, the PCR rates or the complete response rates were higher in the induction chemotherapy arm, followed by radiotherapy alone, versus concurrent chemoradiation. This was actually a non-inferiority study, but the induction chemo arm had more number of CRs than the concurrent chemo radiation arm. And as we know, the induction chemotherapy arm patients failed locally, whereas patients who received concurrent chemotherapy failed distally. So coming to the efficacy analysis, the 2-year PFS was more or less equivalent. The difference was only 3.9%, and it actually favored the induction chemotherapy followed by radiotherapy arm. And adverse events, more incidents of grade 3 side effects were seen, 43.3% versus 60.7% more in the concurrent chemoradiation arm. And quality of life, overall, it took a severe beating, but the induction chemotherapy arm fared much better than the concurrent chemoradiation arm. There was no difference in the target volume or the dosage between the 2 groups. And the induction chemotherapy, because the volume reduced at a smaller target volume and dosage to the lymph nodes than the concurrent chemoradiation. But the overall problem with this whether it is practice changing, definitely not, because the active arm chemoradiation, that is the standard of care arm, was concurrent chemoradiation. The problem is this is no longer the standard of care. The patients are either receiving neoadjuvant chemotherapy with gemcitabine or followed by consolidation chemotherapy after radiation with cisplatin 5-FU. 2 cycles of induction chemotherapy were only given, rather than the 3 cycles that was from the standard of care article from the NEGM, and it was a single center clinical trial. So this is not practice changing, but induction chemotherapy could be an alternative to concurrent chemotherapy in patients. So if the patient had induction chemotherapy and is in a very bad shape and has to receive definitive chemotherapy, definitive radiotherapy, we can probably go with definitive radiotherapy alone, but rather than giving concurrent chemoradiation only in those group of patients. So now coming to the second group, this is probably practice changing, because sometimes we end up seeing patients after patients have come from radiotherapy department where they've received concurrent chemoradiation. How do we improve the outcomes in these group of patients? Should we give cisplatin 5-FU, that is the intergroup study, versus the NEGM article regarding gemcitabine cisplatin? Can we switch to gemcitabine cisplatin in the consolidation phase? Was the study. This again is from China, and most of the patients in China are either in the N2 and N3 group, and these patients fare worse than the N1 group. And again, gemcitabine cisplatin is superior to cisplatin 5-FU in the metastatic or the recurrent setting. And this is the NEGM article by Zhang et al., where they've given induction gemcitabine cisplatin followed by chemoradiation, and it has significantly improved PFS and also OS. And the duration on when should these patients receive after chemoradiation, the earlier the better. And the problem with cisplatin 5-FU is again a 4-weekly regimen compared to gemcitabine cisplatin, which is a 3-weekly regimen. So the scientific issue was whether GP regimens, that is gemcitabine based regimens, can be superior to the standard cisplatin 5-FU regimen in patients with N2 N3 disease. So this was the study design was cisplatin 5-FU versus gemcitabine cisplatin, and the patients. So around 120 patients were there in both the arms, and it was more or less well balanced. The DNA copy more than 2000 were around 40% of patients in the both arms, and it was more or less all factors were more or less well balanced. So now coming to the patterns of failure, most patients in the cisplatin 5-FU arm failed distally. So the reason why we give consolidation is to see that more patients have systemic control, because unlike other head and neck cancers, nasopharynx patients fail systemically also, and compared to locally. It was seen that with gemcitabine cisplatin, lesser progressions were seen, lesser distant failures were seen, nearly halving of distant failures were seen. And again, the response rates more or less were same. More patients were negative for plasma DNA at the end of adjuvant treatment. And the 3-year PFS, there was almost 12% improvement with PFS in the gemcitabine cisplatin arm compared to the cis 5-FU arm. All other, except for the OS, there was decrease in distant metastasis. There was improvement in the PFS, but the overall survival advantage was not reached because it was too early for us to quantify the overall survival advantage with this. So grade 3, grade 4 toxicities, more or less the cisplatin 5-FU had greater grade 3, had greater acute side effects, but the incidence of more greater than grade 3 or more side effects were predominantly with gemcitabine cisplatin, and more of these side effects were either hematological side effects. So concurrent GP chemotherapy is superior and it is better tolerated, but you have to really look out for hematological toxicities. So if a patient comes with concurrent chemoradiation, it is now better to give them gemcitabine cisplatin rather than the intergroup study cisplatin 5-FU based regimens. Now, this is another study again coming from China, wherein they've to the current standard of care, they've added an immunotherapy agent called sintilimab, which is again predominantly manufactured in China. It is a low-cost immunotherapeutic drug with very good efficacy around multiple tumors. So again, this is what it was discussed in the previous study, the Zhang et al. The NEGM article, where induction chemotherapy with gemcitabine cisplatin versus chemoradiation has shown PFS and OS advantage. But in spite of this, there is a significant number of patients who fail. And as we all know, previously NPX was nasopharyngeal carcinomas were called as lymphoepithelioma because there's a lot of tumor infiltrating lymphocytes. The TLS are very high in this. And also in the metastatic setting, the standard of care now is to give immunotherapy along with gemcitabine cisplatin, because consistently all three molecules, that is camrelizumab, toripalimab, and tislelizumab, have shown significant PFS advantage when given in combination with the doublet agents. So Continuum is a study design, which is a phase 2 study where they've given, was a phase 3 study where they've given sintilimab along with chemoradiation, with induction chemotherapy and radiotherapy, followed by 12 cycles of sintilimab versus the standard of care, that is gemcitabine and cisplatin. So they've only taken high-risk patients, that is N2, N3 disease patients and T4 patients only, because these are the patients which have significantly higher risk of systemic failures. And the primary endpoint was event-free survival, and secondary endpoints are overall survival, loco-regional recurrence-free survival, and toxicities. So around 200 patients were randomized in each arm, and it was a very, very well balanced across both arms, and high number of patients were either T3 and T4. More number of patients were undifferentiated, that is the type 3 nasopharyngeal group were the highest in this study. EBV DNA was the high EBV DNA levels were seen, that is more than 1,000 were the EBV DNA levels, and around 80% of the patients were having a PD-L1 CPS more than 85%. So the compliance of the treatment was very good. Very few number of patients, I mean, almost 70% of the patients, that is more than 2/3 of the patients, continue to receive immunotherapy, sintilimab, for almost 1 year, and compliance to both chemotherapy and radiation were more than 75% in both the study arms. So a significant difference, almost a 10% improvement in event-free survival was there, and almost a 40% risk reduction of events was seen. So this again emphasizes the point that giving these agents immunotherapy in these group of patients who have high risk of systemic disease, there is almost a 10% improvement in event-free survival. Probably this forms the standard of care. If we see the next patient, distant metastasis-free survival, there are almost an 8% reduction, and loco-regional failure was also significantly better. Lesser loco-regional failures were seen in the immunotherapy arm. Again, the overall survival, it is too early to quantify the overall survival benefit. We have to see long-term update about this. Consistent benefit was seen across N1, N2, and N3, favoring, and across all arms, it favored adding immunotherapy than chemotherapy. Immune-related adverse events were seen in around 60% of the patients, and grade 3, grade 4 were only in 10% of the patients. It was very well tolerated. So Continuum study supports that sintilimab combined with chemoradiotherapy is the standard of care in high-risk patients. Probably in our setting, we can consider in patients who are affordable and also are at high risk, that is the N2 and N3 group, but we probably need to wait for the overall survival. So overall, induction chemotherapy with chemoradiation metronomics still remains the standard of care. Probably adding immunotherapy to this backbone might increase the overall, might increase the event-free survival, but we have to wait for the overall survival. Now coming to the common disease that we encounter in our group, in our patient population, there are 3 studies in the early phase, that is, can hypoxic radiosensitizers be used in patients who are not suitable for cisplatin or cetuximab-based treatments? Can we use chemo-IO upfront to reduce the intensity of treatment? That is, can we avoid radiotherapy in a small group of patients? Can we use chemo-IO to totally eliminate local therapy? These are the 3 major abstracts that were discussed. And the first study is adding nimorolizumab. It's about adding a radiosensitizer, nimorolizumab. This is again, this is the standard of care in Danish population, where initially in 1986, 1990s, where the conventional radiotherapy was used, it was seen that adding hypoxia modifying agents, there's an improvement in 5-year local regional control by almost 16%. But this is a limited practice seen in Danish population. So they've identified from the biopsy specimens that there are hypoxia genes signatures. And in this study, the NIMRAD study, they tried to see that with IMRT, can nimorolizumab in patients who have hypoxic head and neck cancers, can this add by improving survival? So this is a UK-based study. It is not the Danish study. It's a UK-based study where they've taken patients with predominantly staged patients from oropharynx, hypopharynx, and laryngeal cancers who are not suitable for monoclonal therapy or concurrent platinum-based treatment. Here they've given nimorolizumab 90 minutes prior to radiotherapy, and this is the study. Actually, the study was supposed to enroll 450 patients, but because of financial constraints, they have limited it to 338 patients. The median age, as you can see, is 73 years, way higher than what we see. A very small fraction of patients were PS2, and most patients were either stage 3 and stage 4, and 66% of the patients were HPV positive. It was well balanced. The study arm was well balanced, around 170 patients in both arms, and HPV positivity was seen in 34% in the nivolumab arm and 26% in the placebo arm. And in this study, even they've enriched patients based on the gene signatures. Even in the gene signature positive arm, nivolumab did not show any benefit in increasing the local regional progression, the disease-free survival, or the cancer-specific or overall survival. So the study failed to show that nivolumab can improve survival in patients who have hypoxic milieu or in patients who cannot tolerate cisplatin or cetuximab. There was increasing nausea and vomiting was seen in as high as 56% of the patients, and also peripheral neuropathy was seen in the experimental arm. So this probably lays the foundation that nivolumab cannot be given in patients in head and neck cancers who have hypoxic milieu, and it is better to give newer agents like docetaxel, which again comes from the Tata group, that lower dose docetaxel might be the choice of drug in patients who are not cisplatin eligible. Now, coming to the third study, that is neoadjuvant nivolumab, which was given for almost a year's time with paclitaxel carboplatin. And then patients were stratified based on the response, whether they had good response or bad response to response stratified chemoradiation or the standard chemoradiation. This is the DEPEND study. And as we all know, the HPV negative group has the worst survival. They have the 5-year survival is less than 50% in these group of patients. And the study intended to select these group of patients who do very bad, that is HPV negative, and try to see if immunotherapy can answer this. And the reason why they want to de-intensify this was, once we give the standard radiotherapy, a lot of lymphatic channels receive radiotherapy, and probably this is the reason, hypothetically, the reason could be that these patients do not respond well to immunotherapy because most of these lymphatic channels are damaged because of radiotherapy. So that is the reason, as we can see here, the lymphatic group receives radiation. In the response adapted therapy, only the primary, if the lymphatic have good response to the induction therapy, only the residual and the primary gross disease receives radiation. So the DEPEND study, again, the study design was 9 weeks of nivolumab, carboplatin, paclitaxel. Based on the response, if the patients had more than 50% response, they had response adaptive radiotherapy with concurrently with chemotherapy, versus patients who received less than 50% response, standard chemoradiation, followed by 9 months of nivolumab. So this was the study design, and they used carboplatin rather than cisplatin. And predominantly, the patients who had very bad prognosis. That is, the HPV negative and EBV negative nasopharyngeal, laryngeal, and oropharynx patients were taken. Patients had significant smoking history. Patients with high-risk disease, that is T4 and N2, were taken. And very good objective response rate, that is 54% responses were seen, with deep responses were seen, and nearly 90% responses were objective response rates was seen. Now, as we can see here, patients who had CPS score more than 1 had the best response. That is 80% deep responses were seen in patients who had CPS more than or equal to 1%. The PFS was 64, and the OS at 2 years was 76%. Now, once they stratified based on patients who had good response versus bad response, patient who had a response adapted chemoradiation had significantly better PFS, 79% versus 46%, compared to patients who, again, even in the overall survival, these patients did well, who had good response and received response adapted chemoradiation. Again, more or less similar data was seen. The toxicity was actually way less in patients who had this kind of response adapted chemoradiation than patients who received the standard chemoradiation, as we can see here. So in conclusion, there was a significant, almost 54% had deep response rates. The response adapted chemoradiation was associated with favorable survival and local regional control, and less toxicity was seen. But only 35 patients were enrolled in the study. We need larger studies to really see that if this could become the standard of care. Now, the last study in this space was immune chemotherapy as single treatment modality in larynx preservation. This is because both
last 5 minutes.
Yes, both surgery and also chemoradiation have significant long-term morbidity like severe dysphagia, being dependent on gastrostomy tube aspiration. This study, the backbone of this study was again a previous MD Anderson study where they have shown that with chemoradiation, the PCR rates are as high as 33% and no recurrences were seen at 5 years. So that is the reason they tried to develop a study where chemotherapy with pembrolizumab could be tried. So pembrolizumab with cisplatin or carboplatin and docetaxel was the hypothesis. What they did was they received pembro, dosi, and carbo or cis for 2 cycles, and patients who had progressive disease within 2 cycles, that is after 6 weeks itself, they received chemoradiation or underwent surgery. But patients who continued to respond received 2 more cycles, and then they've done a biopsy and imaging. And on biopsy, if there was pathological complete response at the site where they've done biopsy, if there was no disease, they continued to give almost 3 months of pembrolizumab, and the patient was on follow-up. So the co-primary endpoints, the primary endpoint was in this study was what is the local regional recurrence, and the two co-primary endpoints are disease control rates, that is at 2 cycles, what was the number of patients who received CRPR and SD, and what is the deep response, that is pathological complete response at the end of 4 cycles. So, and in this study, it was seen that deep complete PCR rates were at the end of treatment, so at the end of treatment, almost 78% of the patients had pathological complete response. And at the end of 2 cycles, the CR rates were only 21.7%. But the end of 4 cycles, the PCR rates have gone up to 78.3%. But what happened was after this, around 40%, that is 38.9% patients recurred. In total, almost at the end of the study, they could see that around 50%, that is 47% of patients, systemic treatment alone could be sufficient. But again, this is a limited patient study, and so they might really need a longer follow-up to really say that this could become the standard of care. So this was really an experimental study. Around 40% patients had response. Now, the problem here is they have not underwent surgery after the 4 cycles of pembro chemo arm. It was only biopsy at that site, and if the biopsy is negative, they thought these patients would be in remission. But around 40% of the patients after having biopsy negative disease also failed. So we need longer follow-up in this study. Now, coming to the metastatic setting in patients who are frail, this is the durvalumab with paclitaxel on a weekly basis. Durvalumab plus paclitaxel on weekly basis was given, and 9 cycles of durvalumab following this 4 cycles of paclitaxel regimen was seen. This was in patients who are frail, patients who are more than 70 years old, who are not cisplatin eligible. So this is a surrogate for the Keynote 48 study that laid the foundation for chemo plus pembrolizumab in early stage, in metastatic recurrent head and neck cancers. So in this study, this was a very, very well tolerated regimen. At 1 year, the overall survival was 63%. At 2 year, overall survival was 45%. So in patients who are frail, this can be tried with weekly paclitaxel with durvalumab, followed by once every 4 weeks durvalumab for 9 doses. The next study, this is actually the practice-changing study in our context. This again an Indian study which was discussed. This compared triple metronomic therapy with the NCCN-based treatment options. And in this study, the NCCN-based treatment option, the most common drug used was afatinib. Other than that, cetuximab, docetaxel, paclitaxel, and all were tried. The study arm had 55 patients exposed to metronomic treatment, around 59 patients exposed to the NCCN-based regimen. Most of the patients, unlike the other Western studies who had oropharynx and hypopharynx patients, we predominantly had oral cavity patients enrolled in this study. And most of the patients received platinum taxane. Very few patients received checkpoint inhibitors in the first-line setting. So in second line, when the standard of care was compared to the TMC oral metronomic treatment, there was nearly a almost a 60 days improvement in survival, and the progression-free survival, almost a doubling in progression-free survival was seen, and very minimal toxicities in the treatment arm, that is the TMC arm, was seen. So these are the agents which patients received. Most patients received afatinib, docetaxel, and paclitaxel, and this probably is the standard of care if the patient has not received metronomic treatment upfront. So at least in the second line, there is definite benefit of using triple metronomic chemotherapy. Probably an ideal study arm could be triple metronomic chemotherapy with low dose immunotherapy, but we will have to wait for such studies. The last study was a bifunctional EGFR TGF beta inhibitor BC101, which was given in combination with pembrolizumab. So this is initially in patients who have high EGFR driven tumors, that is pancreatic, colorectal cancers, head and neck cancers, were used on a dose escalation study, phase 1 design, followed by a dose expansion. Simon 2-stage design was used. The recommended dose, the dose was 1500 mg IV, that is both single agent and combo with pembrolizumab. 15 mg IV weekly dosing was the maximum dose at which there was full saturation of EGFR, neutralization of TGF beta, which is the moiety, which is a ligand for EGFR receptor. And at this dosing, there was a significant. So around the median 33 patients were enrolled, median age was 65. And again, even in this study, most of the patients were oropharyngeal or hypopharynx patients. Very few oral cavity patients were seen. PDL, the CPS score more than 20 was seen in around 45% of the patients. So most common adverse events were skin toxicity and mucosal bleeding, and infusion reactions were seen. So coming to the efficacy of this study, the CR rates, overall response rates were seen in nearly 50% of the patients, and CR was seen in only 1%, in only 3% of the patients. And this benefit was seen irrespective of HPV positive or HPV negative, CPS positive or CPS negative. All patients really derived benefit, and in patients with CPS more than 1, the median time to response was very fast. 1.4 months the patients had response, and the duration of response in the median PFS was 4.8 months. So in patients who fail multiple lines of treatment, probably this could be the alternative. So thank you all. Thank you once again. As I told initially, not much practice changing data predominantly in the head and neck space, except for the oral metronomic data in the second line, which is relevant in our practice. So thank you, and I'm open to.
Thank you, Deepak, for a wonderful, extensive talk. So, what is your practice in induction in nasopharynx?
So gemcitabine cisplatin is what we are now following. So 3 cycles of gemcitabine cisplatin, and then we are starting the patient on chemoradiation. We are seeing very good tumor shrinkage. Patients who come with bulky lymph nodes, we are seeing very good response, necrosis, shrinkage of nodes. So we have moved to induction chemotherapy. Sometimes where radiation oncologists give chemotherapy and then they come back to us. We usually used to give 3 cycles of cisplatin 5-FU, and now probably would be changing to gemcitabine cisplatin in this group of patients.
Deepak, all your patients are taking induction chemotherapy?
Sir, bulky disease patients, we are giving induction chemotherapy, sir. And most of them, at least last 5 years in practice, all of them have come with bulky lymph nodes only, sir. So,
maybe non-bulky has not come to you first.
Sir, hardly we've seen 5 patients, sir. I somehow nasopharynx, Kidwai, we used to see more patients, sir. In private practice, 5 patients over the last 5 years.
Okay, so presence of HPV infection, does it make any difference?
No, sir. I think all data,
like in the sense of immunotherapy, I'm asking, use of immunotherapy.
We are not checked in metastatic setting, sir. Recurrent metastatic setting, we have not checked. But data at least says that in the patients who are viral etiology, they do better. So, but we are only certifying based on CPS scores in private practice.
So, metronomic therapy, you are using the same combination or any different?
We are using the same combination, but in place of erlotinib, we are using geftinib, sir, and we are using nivolumab lower dose. We are using 40 mg. We are using 40 mg, sir. So
what is your experience with 40 mg?
Sir, currently, I have around 8 patients, sir. All of them are doing well with that, sir. The PFS that we are seeing is 8 months, 9 months in private practice, sir, in practice. All of them are doing well. Yeah.
So even 40 mg I have used for one of the Hodgkin's lymphoma who was already treated with nivolumab more than a year back. Okay. So just 1 cycle he has come with almost CR.
Yes, sir. 40 mg is really working well, sir. I think BMS is not promoting the data enough. Sir, the data.
You don't want to promote.
The data is without nivolumab, sir, the second line data. Actually, with nivolumab, the curves would have split even much better, sir.
Okay. Okay. Thank you. Thank you very much.
Thank you for the opportunity.
Thank you. So now I'll move on to the last topic, and that is update on genitourinary cancer and supportive care. I will not take much of your time. So I'll just go to very important practice changing updates. So not much practice changing updates when it comes to genitourinary cancer, but just wait for me to conclude the last study I'm going to present in supportive care. That is going to be really practice changing for us. So just bear with me for a few minutes. So let's proceed with the genitourinary cancer update. So first, when it comes to renal cell carcinoma, we all are using lenvatinib plus pembrolizumab. So this was compared versus sunitinib in advanced first-line RCC. So this is the 4-year pre-specified overall survival analysis. We all know that the PFS advantage with len pembro versus sunitinib. So it is already approved drug first line for a patient with clear cell RCC in all the IMDC stratification. This is the study design. Then pembro versus sunitinib. This is the overall survival analysis showing the significant p-value, but not numerically significant difference when it comes to overall survival. But when it comes to the overall survival based on the subsequent anti-cancer medication, it is showing significant overall survival benefit with hazard ratio of 0.55 and not reached. The median survival was not reached with len pembro, and it has shown the benefit in the different subgroups. When it comes to the risk stratification, favorable. It has not shown much difference, but when it comes to the intermediate versus poor, it is showing some benefit, and it continue to show the PFS benefit with significant p-value. Again, when it comes to the different risk stratification, it is showing good PFS, and again, patient achieving CR, there is a very good survival. This is the side effect profile. This all we know. So conclusion is, len pembro continue to demonstrate clinically meaningful and durable benefit in first-line treatment of patient with advanced RCC at 4 years follow-up. There is no new safety signal. So one more combination what we use is pembrolizumab plus axitinib. So this is a 5-year analysis of Keynote 426 study. So this also combination we are using in our practice. The median OS was not reached. PFS 15 versus 11 months showing significant benefit, and this is already approved in first line setting. So this is the study design. I am not going to that. The PFS benefit was there. This we all know, but when it comes to overall survival, again it's showing the hazard ratio of 0.84, the benefit in favor of pembro plus axitinib. So that this is based on the favorable risk, stratification favorable risk, the overall survival showing some difference. It's a significant PFS benefit even in patient with intermediate and poor risk. It's showing a more benefit than the favorable risk with respect to overall survival and also the progression-free survival. So this is the subsequent anti-cancer therapies. So when the patient progresses on immunotherapy, we go for TKA, and when the patient progresses on TKA, we go for immunotherapy. That's what it is. The patient has received. This is the overall survival showing significant benefit. So this is all the patient who complete the pembrolizumab of 1 year, that is showing the benefit. The Keynote 426 represent the longest follow-up data to the of the combination of checkpoint inhibitor plus VEGF TKA in first-line clear cell RCC, and it continued to demonstrate overall survival, progression-free survival, and response rate, and substantial percentage of patient complete 35 cycles. So this continued to support the use of pembro plus axitinib in first-line RCC. So there are other studies in kidney cancer. One is in the early stage, and I'll come to that. And one more is in the later stage in the second line, and then followed by the bladder cancer. So we know that in the localized renal cancer after surgery, we have 2 approvals, sunitinib and pembrolizumab. This was in 2017 and 2021. This is the adjuvant nivolumab plus ipilimumab. We know that nivi and ipo is going to benefit the patient with advanced disease, but this study they have given in the adjuvant setting after surgery for patient with high risk of relapse after nephrectomy. So this study actually nivo ipi versus placebo. This shows that no much different with respect to disease-free survival. There are few subgroup analysis showing the sarcomatoid features may show the benefit, and PDL1 more than 1% may show have some benefit and grade 4, but this is all not concluding the remarks. It is only the hypothesis generating. Maybe we should take this subgroup and do the studies. So then only we can come to some conclusion. So this is again same. I told grade 4 and sarcomatoid showing some differences. PDL1 more than one, some difference. So nivo-EP, despite its activity in metastatic disease, ineffective in the adjuvant setting and should not be offered to the patient in this context. So although some patient subsets, sarcomatoid and PDL1 positive, appear to benefit, these were exploratory subsets and should not be used for clinical decision making. So then, so when we use the patient on first line, either immunocheckpoint inhibitor or TKI, ultimately the patient will progress. So after progression, should we, when the patient has already taken immune checkpoint inhibitor, can we re-challenge with immune checkpoint inhibitor? This is the study Contact 03 study. They have to find out the efficacy and safety of atezo plus cabozantinib versus cabozantinib. After progression with prior immune checkpoint inhibitor in metastatic RCC, the phase 3 study. This study is atezo cabo versus cabo was the two arms. It's showing no significant difference with respect to progression-free survival and also the overall survival with increased toxicity. So following progression on or after treatment with PDL1 or PD1 therapy, the addition of atezo cabo was ineffective and not associated with a harm. So the question is this disappointing observation generalizable to all immune checkpoint inhibitors in the post-immune checkpoint inhibitor setting? Until new level 1 evidence shows otherwise, the answer is yes. So in post-immune checkpoint inhibitor setting, metastatic RCC patient should not be re-challenged with immune checkpoint inhibitor-based therapy outside a clinical trial. We should not be using immune checkpoint inhibitor following progression on immune checkpoint inhibitor. So this is the bladder cancer. We all know that the bladder cancer, the neoadjuvant cisplatin-based chemotherapy, either with gemcitabine cisplatin or now dose-dense MVAC is the standard of care. And lymph node dissection, I'll come to that study. This is the study what I was telling, phase 3 trial, surgical trial to evaluate the benefit of standard versus extended lymphadenectomy in radical at the time of radical cystectomy for muscle invasive urothelial cancer. So this is the standard lymph node dissection, external, internal iliac and operator nodes. In extended lymph node dissection, they have done presacral, distal, IVC and aortic node dissection that is showing no significant difference, and also the mortality. So extended lymph node dissection does not improve the DFS or OS and should not be incorporated into our practice. This is metastatic urothelial cancer. Cisplatin-based regimen, this yielded survival rates, and when cisplatin is ineligible, the MVAC or GEM-CIS followed by available maintenance is the first line. If cisplatin is ineligible, then GEM-CARB followed by available maintenance is the treatment of choice. And some patients we can use the checkpoint inhibitor monotherapy for selected patients. Now we have what is called the enfortumab vedotin plus pembrolizumab, recently approved by FDA for metastatic urothelial cancer. That is EV103 study. This is the study that is a dose escalation cohort A. Long-term outcome of enfortumab vedotin plus pembrolizumab in first-line cisplatin ineligible locally advanced or metastatic urothelial carcinoma with nearly 4 years of follow-up. So this is the study design. I will not go into this. This is the reason for cisplatin eligibility. And you can see clearly the overall response rate is excellent, 58 to 85%. So this is among the highest overall response rate we have seen in first-line setting for the urothelial cancer. So based on this, the US FDA has approved this drug combination, and this is the 2-year overall survival, 26 months. And peripheral neuropathy is the most common toxicity, and maculopapular rash is the one we need to be worried about when combining these two drugs. So this enfortumab vedotin plus pembrolizumab has received accelerated US FDA approval of first-line cisplatin ineligible patient based on the encouraging overall response at 68% with manageable safety profile. So now we'll move on to the prostate cancer. So these are the few updates. I just go in brief. So the PEACE-1 study, this is the study design. So this is in the local treatment in the setting of metastatic disease. So what is the role of local treatment in patient with metastatic prostate cancer? That is the use of radiation. So with hormone-sensitive prostate cancer, this study was randomized into standard of care or standard of care plus abiraterone, and with or without RT. So this is the patient characteristics. You can clearly see the radiographic progression-free survival favors abiraterone plus radiation. So that means if the patient has a low volume disease, especially like one metastatic lesion, go for a standard of care and androgen deprivation therapy plus abiraterone plus radiation to the local site. That is going to give you a good radiographic progression-free survival for versus without not giving the radiation. But there is not much significant difference with respect to the overall survival. And even the time to serious genitourinary events are also better in patient receiving radiation in low volume disease. So there are other data also available. So this is the other data what we have seen showing some benefit, and this is again the Stampede study. So this is one more oligometastatic study, and this is the S1802 study. It is still ongoing. So combining prostate RT with intensified systemic treatment appears to improve radiographic progression-free survival and serious genitourinary events in low volume metastatic castration-sensitive prostate cancer, but no detectable impact on prostate RT and overall survival in PEACE-1 study. And there are other studies where Stampede 1, it has shown the overall survival benefit with a low volume group. And there is one more oligometastatic trial showing the overall survival benefit, and one more study is ongoing. So what about the PARP inhibitors? This is the one study that is called TELAPRO-2. It is a phase 3 study of talazoparib plus enzalutamide versus placebo plus enzalutamide in first-line treatment of patients with metastatic CRPC. This is in the CRPC harboring HRR gene alterations. So we know that the DNA repair gene mechanisms, I'm not going to it. So we all know that the rucaparib is already been approved in 2020, May 15, with BRCA1 and 2 mutation, either germline or somatic in patient with metastatic CRPC. And after 4 days of rucaparib approval, the olaparib was approved. And this was mainly for patient with somatic or germline HRR gene mutation in metastatic CRPC. So this is why we should use PARP inhibitor with the new hormonal agents. The PARP involved in the androgen receptor dependent transcription. PARP inhibition may increase the activity of newer hormonal agents. And other way, the newer hormonal agents induced HRR deficiency, increasing the susceptibility to PARP inhibition. So both will combinedly have a synergistic effect with anti-tumor activity in HRR mutated and HRR non-mutated prostate cancer. So we already have 2 studies, the PROPEL study and MAGNITUDE study. The PROPEL study used abiraterone and olaparib combination. MAGNITUDE used abiraterone plus niraparib combination. Both have shown the benefit in terms of progression-free survival. So this is the TELAPRO study. It used talazoparib plus enzalutamide versus placebo plus enzalutamide. So this TELAPRO-2 study showing radiographic progression-free survival benefit in overall population, and with similar outcome we have seen in PROPEL study with the use of abiraterone plus olaparib, and also in the MAGNITUDE study with the use of abiraterone plus niraparib. So this is again the TELAPRO. They used all comers population and also in the HRR mutated population. So these are the previous treatment on this thing. So this is the radiographic progression-free survival. It is showing the significant benefit with the use of talazopro plus enzalutamide. And this is overall survival showing some difference. So based on this study, the TELAPRO plus enzalutamide resulted in statistically significant improvement in radiographic PFS. The patient with HRR gene alteration, OS data is still unmature. So based on this, May 31st, just last 15 days back, the US FDA has approved the olaparib with abiraterone and prednisolone for patient with suspected or deleterious BRCA mutation in metastatic CRPC. This combination was approved now with olaparib plus abiraterone in CRPC with BRCA mutation. So balancing the outcome is always the important. The next study is a LUPARP study. It is a phase 1 study of lutetium PSMA therapy. We know that the lutetium PSMA delivers a payload of beta radiation to PSMA expressing tumor cells. So this lutetium causes single strand DNA breaks that will be repaired by the PARP enzyme. So when you inhibit the PARP enzyme, this single strand breaks will be converted into double strand breaks and that will become lethal. That will again kill the tumor cell. So that is the mechanism. So this is a phase 1 study. I will not go into it. It is showing a very good response rate of 65%. So it's very encouraging for us to do further studies with the use of this. So this is RP-LND in stage 2 seminoma. When it comes to seminoma, usually we don't talk about RP-LND. So this is a study which looked at the role of RP-LND in patient with stage 2A and 2B seminoma. So this is what they have included. So we know that the 20-year survival now for seminoma is increasing more than 90%. So they have included the patient with stage 2A and 2B for primary unilateral RP-LND. This was in 5 centers, 94 patients. So these are the patients, 59 patients they have included, and this is the survival. So conclusion is primary RP-LND is a promising treatment option in seminoma stage 2A and 2B, less than 3 centimeter, and the risk of late morbidity and mortality is minimal. Overall, these results can apply to clinic for this patient population, and also we need additional follow-up, which may be helpful to ensure that there are no other safety signals. So next, this is the one study I wanted to present. This is a randomized trial of fixed dose capecitabine. So this is as a supportive care I am presenting because to reduce the toxicity of capecitabine, they have done this study. This is a fixed dose called capecitabine compared with standard dose capecitabine in a metastatic breast cancer. It is a X7/7 trial. So we know that with the use of capecitabine, we have unique side effects of hand-foot syndrome, diarrhea, and stomatitis. So usually the capecitabine dose is 1250 mg per meter square, twice daily, day 1 to day 14 for 21 days. So with a mathematical background of the maximal cytotoxic effect of capecitabine occurs after 7 days of therapy, beyond which time the toxicity increases. So based on this, they have planned to give 7/7. So this is how they have done in capecitabine. They have given a flat dose of 1500 mg, that is 500 mg tablets 303 for 7 days, followed by 7 days rest. And again, this is the standard dose 1250 mg per meter square for continuous 14 days, followed by 7 days rest. So this is the patient. This is showing the similar progression-free survival when you use 7/7 capecitabine. And this is also the progression-free survival and response rate looks similar. Overall survival looks similar. Even the overall survival at landmark analysis, it all looks similar. The exploratory subgroup analysis, not much different. So what the difference is in the toxicity. You can see here, there is a significant benefit, statistically significant reduction in diarrhea from 20% to 2.5%, almost 10% reduction in diarrhea. Again, you can see with respect to hand-foot syndrome grade 2 to 4, there is almost 80% reduction from 15% to 3%. And again, oral mucositis from 5.5% to 0. And neutropenia also reduced from 27 to 21%, may not be significant. But when it comes to diarrhea, hand-foot syndrome, and oral mucositis, these are all less when you use the capecitabine 7/7. So that is a big advantage of using this schedule. So in metastatic breast cancer, the fixed dose 1500 twice daily of capecitabine on day 7 and 7 day on, 7 day off schedule. When compared to the fixed dose, it is showing similar efficacy and reduced incidence of hand-foot syndrome, diarrhea, and stomatitis. And this may be a very good alternative regimen for patients with metastatic breast cancer who may not be able to tolerate the full dose. So this is the practice-changing study from India, from AIMS, Delhi. So this is a randomized double-blind placebo-controlled study of topical diclofenac in prevention of hand-foot syndrome in patient with who receiving capecitabine. So we know that the capecitabine is a oral drug known to cause hand-foot syndrome, around 25 to 75% of the patient. So usually it needs a dose modification in up to 10 to 25% of the patient, or dose reduction, and up to 10% may have permanent discontinuation. So just see that the grade 2 means skin changes with the pain. This is a grade 2 hand-foot syndrome. So with this, all this background, so we all know that celecoxib is more effective in preventing the hand-foot syndrome, but because of its cardiotoxic effects, nobody uses. And we also have a urea cream that is known to prevent the sorafenib-induced hand-foot skin reaction. But these are all they advisable, but there is inadequate evidence to make recommendation regarding the pyridoxine also. So with all this background, these are the drugs were used in hand-foot syndrome: topical urea, pyridoxine, celecoxib, and vitamin E. So we know that the cyclooxygenase 2 inhibition is proposed in the mechanism of hand-foot syndrome. So this and again, the topical COX inhibitors were extensively used in osteoarthritis, and the safety is well known. Based on this, the hypothesis was generated that is topical diclofenac will be effective in preventing hand-foot syndrome with a COX inhibition. So this is the study design. So what they have done, patient taking capecitabine was stratified into twice daily application of 1 gram 1% topical diclofenac on both the hands during 4 cycles capecitabine. So what they call is FTU, finger tip unit. They'll take the ointment in a fingertip and apply on the one aspect of the hand, and same one more fingertip unit they'll take and apply on the back of the hand. Again, the opposite hand, same thing is repeated. So this they have to do for 14 days when they are taking capecitabine for 4 cycles, and the other arm they have given the placebo gel. And the endpoint is development of hand-foot syndrome more than grade 1 or all grades of hand-foot syndrome and time to hand-foot syndrome and other outcomes. So this is what I have told, a fingertip unit and study duration 4 cycles. So this is the schedule of assessment. 120 patients were included in the each arm. This is the consort diagram. This is the baseline patient characteristics. So the primary outcome, you can see here, only the 9.5% of the patient developed a grade 2 or hand-foot syndrome, and 3.8 versus 15%. That is what statistically is significant. You can see here, when you use the diclofenac gel, the development of hand-foot syndrome is 3.8%. With placebo, it is 15%. So almost a 12% reduction in the incidence of grade 2 or more hand-foot syndrome when you use the diclofenac gel. And the absolute difference was 11.2%, and relative risk is 0.25. So there is a 75% reduction in risk of developing hand-foot syndrome grade 2 or 3. So this is again with respect to outcome in all grades of hand-foot syndrome, almost that 12% improvement. So this is a very good practice changing, and also you can see that the diarrhea, it's all a similar side effect, and because it is less when you use in patient with diclofenac, but I don't know what is the mechanism for this. The quality of life also better when you use diclofenac gel. So this is a subgroup analysis showing the benefit with the use of diclofenac in all subgroup of patient. So conclusion is the topical diclofenac gel significantly reduced the incidence of grade 2 or 3 hand-foot syndrome. All secondary outcomes aligned with the primary, that is lower incidence of all grades hand-foot syndrome. Dose reductions were less common, and there is improved quality of life, and there is also higher adherence and similar toxicity profile. So the benefit appears consistent across all the subgroups. So conclusion, these number of events were less than the anticipated, maybe the placebo effect, or the mean dose of capecitabine was less than 2000 milligram per meter square, or ethnic variation. So this trial supports the 1% diclofenac gel as a new standard of care to prevent capecitabine associated hand-foot syndrome. This is really practice changing for most of the experts from ASCO. They have told that this is one of the practice changing abstract for us. Thank you.
Lokesh, one quick question.
Yeah.
You are the diclo gel, you said, no? It is the same gel, it is available in the market or any?
Yeah, as per my knowledge, it is the same gel what is available in the market. So even I have checked in the Google 2 days back. So the 1% diclofenac gel is available. So
available
for osteoarthritis. They are already using for osteoarthritic patient for pain reduction. So same gel.
The originators are only plain diclofenac, but the generics have combinations. That's why I asked.
I think the Alchemy is having the single diclofenac gel. There are 1 or 2 brands I saw in the Google. I wanted to suggest for my patients taking capecitabine. So I wanted to suggest, I was
What
checking.
about in the setting of already established hand foot?
Established that they have not seen to it actually. Maybe that is a hypothesis generating. We have to, we can try use, or we can do a study in patient who have already developed hand-foot syndrome. So maybe some 2 weeks back, I got a call for a clinical trial in hand-foot syndrome for the use of diclofenac gel. So I was really thinking, and they asked me, I said, I don't get so much of patient with hand-foot syndrome. So I don't know, really, they didn't come back to me after. Maybe this was the study somebody wanted to plan in a big way.
Nice. Thank you.
Thank you.
Thank you.
Thank you, sir. And I would like to thank all the faculties who have joined and spared their time today for this great 2 days academic feast. I would like to take an opportunity to thank our academic partners, AstraZeneca, Roche, Viatris, Lupin Oncology, Torrent, Alchem, Samarth, RPG Life Sciences, Netco, Edley, and Merck. I would also like to thank my colleagues Gitika and Vishal and the support team, who has been a great contribution to execute this webinar. Thank you, Dr. Lokesh.
Okay.
Thank you, all the faculties. Good night,
So,
everyone.
Thank you. I would like to
Yes.
thank you all, the supporting team, the Global Oncology Forum. All of you, thank you very much for making this event a very successful one.
Thank you.
Thank
Sir.
you very much.